of life here in India, from the time immemorial, we have had culture of samvad, that is partaking in our learnings with our gurus, seniors, and colleagues, so that we can expand our horizon of sacred knowledge, which has capability to save someone's life.
We are honored to have an opportunity to learn from revered Dr. Narayan Jayshankar Sir, a celebrated consultant otolaryngologist and lateral skull-base surgeon practicing since 2000. He is author of renowned works like Atlas of Neurotology and Lateral Skull-Base Surgery, and also author of Atlas of 360-degree skull-base surgery. He is well known for his work on lateral skull-base surgery, endoscopic surgeries, and facial nerve surgeries. Has been invited to more than 250 workshops in India and abroad, is a contributor to various textbooks, and is a reviewer of various index journals. He is also member of renowned institutions like Association of Otolaryngologists of India, Society of Otology and Neurological Society of India, and Indian Society of Rhinology and Skull-Base Surgery. Presently working with Leelavati Hospital and Research Center, PD Hinduja Hospital, and Nanavati Max Super Speciality Hospital. Without much ado, let us start our academic bonanza session, as the full house audience is already waiting for the session to begin. Hereby, I request all the delegates to type down their queries and inquiries on WhatsApp group and keep the group active, so that we forward the queries to OT and we all take maximum benefit of the group. Over to Dr. Jayshankar Sir.
So good morning to one and all. Can you hear me?
Good morning, sir. Yes, sir.
Good morning. So first of all, thank you very much to Dr. Sejal, Dr. Jui, Dr. Neerav, and everyone else who has been instrumental in calling me once again to Rajkot. It's of course a proud honor and privilege to come back here. I had shown a dissection 1 year ago, I think approximately. And again, to get another opportunity to showcase the same is a great honor. And thank you all very much. So I would very much want to teach for all the juniors around. I know there will be a lot of seniors here who will know a lot of the stuff that we are going to show, but I'm going to dwell today on everything from beginning to whatever you want as advanced cases. So my initial part of the dissection is all going to be on all the basic procedures. And as we go in, we'll go into the advanced procedures, which will help even the seniors. In the meantime, if there are any questions, please feel free to ask me. I will volunteer a lot of information, but still, if you can, if you'll ask questions from there, if there are any doubts, I can show everything on the cadaver and we can go on proceed with the dissection as fast as possible. The reason I'm not wasting much time on talking is because we have lots to show. And I think there are 2 lectures we will try to push in whatever we can. If I can show you the whole skull base in 4 hours, that would be very nice, but we'll try our best to show whatever we can. Okay, we'll take it as it goes. So again, everyone, and hope you all enjoy a good Sunday. Hello. Yeah, now I have the collar mic. Endoscope. Can you get an audio? 0 degree endoscope. Hello. Yeah, auditorium.
Hello. Yes, sir.
Yeah,
We are getting the audio.
Can you hear me?
Yes, sir.
Hello. Morning, Narayan sir. This is Yash here.
Yeah, hi Yash. How are you?
Very fine. Good to see you back.
Yeah, good to see you. Missed you at Morbi.
Yes, I did. But I witnessed the surgery. They were lovely.
Thank you. Always nice to have you around, Yash. Yash, I want you to contribute with all your expertise, okay?
Sir.
टीवी को ऐसा लाना. Wow, nice. Good. I believe we have a fantastic cadaver here. With all due respect, just a word of gratitude to the people who have managed to donate this cadaver to us. Okay. And because of this person, we'll get to learn a lot today. Okay. So
Absolutely.
everyone just have a silent prayer in your mind for this person who's going to help us learn a lot today. Give me a ballpoint probe. Yash, can I start? Are
Sir.
there people in the auditorium?
Yes, yes, sir.
Okay. How is it? 10
Full.
people? Full?
It's almost full. Yeah, all the juniors around.
Oh, okay, good. So I was not expecting it to be full, to be honest, so early in the morning. But if it's full, I'm happy. We can get started. Okay. Mitram, everyone around, start. Okay. So here I have a lovely team assisting me. Vaibhav, Jeet, Mitram, Akshada, everyone over here, all my fellows. And they're all going to assist me for the dissection today. So before I start the dissection, what's the sound? Okay. So before I start the case today, just a quick overview for all junior people. What is anatomy of the nasal cavity? Okay. Now here we are into the right nasal cavity. Can you all appreciate everything?
Yes, sir.
Do you have a good picture?
Yes.
Okay. So in the right nasal cavity, this you can see is the nasal septum. All right.
Yes. Yes,
This
sir.
is the inferior turbinate. All right. What you do is you go beside the inferior turbinate or inferior to the inferior turbinate, and there you go into the choana. Can you see this choana here? So for
Yes, sir.
people, this is the choana. What you're looking at, you're looking into the nasopharynx. This is the region of the eustachian cushion. All right.
Yes, sir.
This is the region of the torus tubaris and eustachian tube. There. Okay.
Yes, sir.
This is the eustachian tube orifice hiding over here. All right. And this is the region of the nasopharynx. Clear, everyone?
Yes, sir.
All right. Now, here, as I come out here, this is the middle turbinate. Okay. This middle turbinate has got an axilla which is attached here to this lateral nasal wall. This turbinate generally attaches itself to the junction between the medial and the lateral lamella of the cribriform. If you see over here, this is the cribriform plate. All right.
Yes,
So
sir.
this will attach itself. This is the medial lamella. Okay. And like that, you have a lateral lamella going up. So this turbinate generally goes and attaches to the junction of the medial and lateral lamella of the cribriform plate, though its attachment can vary. So starting from there, it has got a vertical limb which comes straight down. Then it has got horizontal limb which goes posteriorly. And then it has got one more limb which turns laterally over here, as you can see. Can you see that?
Yes, sir.
The lateral nasal wall. Okay. So three limbs. One is a vertical limb, a horizontal limb, and a limb going laterally. So they are all in three different planes. All right.
Yes, sir.
All right. So what is 1 minute? Let me clean the scope. So what is the middle meatus? Middle meatus is this area lying deeper to the middle turbinate, right?
Yes, sir.
Inferior meatus is the part lying deeper to the or medial lateral to the inferior meatus. Now, if I move this inferior turbinate this way, that's the inferior meatus. If I had a 70-degree scope, I would be able to probably show you a opening of the Hasner's wall or the nasolacrimal duct over here. All right. The
Yes,
generally
sir.
opens over here, and that's the region where it where you find the nasolacrimal duct opening. All right. We'll see if we get a 70-degree scope. I'll show you that as well. Now, when you look into the with this endoscope, you're looking at the 70. Getting little bit. ये इसको मेरे को just saline दे दो, Savlon मत देना. Savlon से bubbles आते हैं. Just give me saline. You're changing to 70. Okay, I'll just show you with the 70 quickly the inferior meatus, and I'll show you the opening of the nasolacrimal duct. Require a Freer's elevator. Not clean. We have not done the white balance. Okay, so now I look into the inferior meatus over here. What I'm doing is I'm pulling this inferior meatus a little bit here. Okay, and I'm looking inside, it's a little tough. But I just hope you can make out this notch over here. Can you make this out here?
Yes, sir.
This is the notch where you'll get the nasolacrimal duct opening into the inferior meatus. All right.
Right.
And
Right,
then
sir.
press on the nasolacrimal area, you will find some amount of fluid coming out or tear fluid coming out from that area. Okay. Give me the 0-degree endoscope once again. So coming back to the nasal anatomy here. Okay, it's okay. Now it's clean. I don't want the Savlon. This is better. Okay. So you can see over here, this is the middle turbinate. Now, middle turbinate has this area over here. This is called the region of the uncinate process. Okay. This
Yes, sir.
uncinate process is attached to the lateral nasal wall. If you palpate this, you know this. You can actually see this groove over here, which says that the uncinate process is attached here. You can make out this groove, softer piece over here, right? So, uncinate process here comes from superiorly, goes like this, and actually has a little bit of a horizontal orientation as well, which then covers the area called the infundibulum or the hiatus semilunaris, which if you open up, you will see the opening of the maxillary ostia. So the maxillary ostia will be hidden behind this. Now, uncinate process has got varied attachments. Okay, it can attach like this to the lateral nasal wall. It can go up and attach to the skull base. It can go and attach like this to the medial Okay. So depending upon its anatomy, which you have to study on the scans, we decide about how to go about excising it. Now, there are various methods described for removing this turbinate. Some people take a incision over here with a blade, right? Wrong, because just lateral to this is going to be your orbital plate. All right. So if you take it with a sickle knife and you just go deeper in, it's possible you may just breach it and go past the orbit into the orbital fat. Okay. So people use freers, people use sickle knife. That is why nowadays, yeah, backward biting. So that is why people have now changed to the retrograde method. In the retrograde method, it is far safer. And what we do is we go behind this. Give me a ballpoint pro 1 second before you give this. In a retrograde method, what do you do is ballpoint. You go behind this, you would start biting from the free edge towards this edge, right? Again, for all you juniors, this is the area of the nasolacrimal system here, this area. Okay.
Yes, sir.
Anterior to your uh, middle turbinate. This area, if I clear up, I will get the nasolacrimal system and the nasolacrimal duct. So anyone doing DCRs know that this is the area you need to be. Now what happens is if I take this uncinate process here, and you can see I'm palpating bone over here. Can you see this?
Yes, sir. Yes, sir.
Okay. So once you know this is bone, if I bite into this bone, it's possible I may catch on to this nasolacrimal system and cause damage to the nasolacrimal duct. So there is a lecture I will show you about the nasolacrimal system and how to handle complications. There's a lecture on complications of FES. But by and large, understand that this is the bony projection. You all know this is the region of the endolymphatic sac, and you really don't want to bite into this bony projection. All right?
Yes, sir.
That is one thing. So you see over here, I already can see a part of it, but this is just for you all to figure out. I'll show you what is to be done ideally. Okay. Give me a backward biting.
Sir, before that, quickly, if you could show us the superior meatus and the sphenoid sinus ostium.
Give me a Freer's elevate. So again, what I'll show you is here, this is the middle turbinate. Now, many procedures or even in life surgeries, what we do is we lateralize the middle turbinate. Okay. Lateralize the inferior turbinate. So for inferior turbinate lateralization, you just have to fracture it little medially and then shift it on its head here. See this? It's gone laterally. Can you see that? You feel
Yes,
that?
yes, sir.
And immediately the spaces improve. Same way, middle turbinate here. Now, on the top here, if you manipulate this area, you're going to immediately get a CSF leak. So you must never manipulate it over here. What you're supposed to do is go on the posterior edge over here, this horizontal limb, and you can manage to just fracture this very gently, just a crack that you'll feel like an eggshell cracking. Can you see that?
Yes, sir.
Yes, yes, sir.
So just do this. This is enough. And here, as you look inside over here, you'll start seeing the superior turbinate.
Superior turbinate. Yes, sir.
This is the region of the superior turbinate. Lateralize the superior turbinate. Okay, you see this? I'm doing this, lateralizing the superior turbinate. What we do is lateralize and then put patties over there because lateralization causes some amount of oozing. All right. So once
Yes, yes, sir.
I start exposing the region, give me a suction. I must compliment Dr. Sejal for a lovely fresh cadaver over here. Okay. Suction.
Yes.
I don't want to wash. Is it focused? Is it focused for all of y'all?
So if you could focus it a little better.
Okay, it is sharp over here.
Okay.
Tell me when it is the best for you.
Can you clean the
Perfect,
scope,
perfect,
sir?
sir. Yeah.
Okay. Anyway, give me a ballpoint probe. So again, what Yash has asked me to do is show you this area. Okay. Now, what is the importance of this area over here? Can you see? This is the superior turbinate. Minute
Yes, sir.
here you'll start seeing the region of the sphenoid ostia there.
Yes,
Alright.
sir.
Yes, sir.
Yes, sir.
Now here, you can see this is the upper part of the choana. As juniors, you were always taught that 1.25 centimeters above the choana is your sphenoid ostia.
Spinal ostium.
Okay. So what is a definitive identification? We don't have a measuring ruler, right? But if you see this, this is the front face of the rostrum of the sphenoid bone, right?
Yes, yes, sir.
Correct. So here, what you can see is from the choana, this bone starts coming towards us and it disappears away from us. Okay. You're seeing it in a two-dimensional plane. It's not straight. This part is more towards us than this part or this part, right?
Yes, 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 sir.
Front face of the sphenoid, as in where it starts going away from you, just adjacent to the septum, this area is going to be where you're going to locate your sphenoid ostium most definitively. Can you see that there?
Yes,
sir.
yes, sir.
So that's going to be. So sometimes it's covered over by membrane. Sometimes you have to go through the membrane with a suction or a Freer's elevator. But by and large, this is the area called the sphenoethmoidal recess. Now, why is this sphenoethmoidal recess important? Is because you all know sphenopalatine artery starts from here somewhere, okay? In the
Yes, sir.
posterior
Yes, sir.
of the middle meatus. Sphenopalatine artery gives out numerous branches. It gives out branches to the posterior ends of middle
Middle
turbinate,
turbinate.
goes down, gives out branches.
Inferior turbinate.
Inferior turbinate here, gives various
Septum.
branches down to the septum over here, right? So the
Yeah.
reason we talk about this is the posterior nasal branch of the sphenopalatine artery. It passes
Uh,
this area.
Pedicle for adult trips, sir.
Correct. So it has not just a single blood vessel, it is multiple blood vessels over here, okay? And it comes and arborizes and sort of it supplies the nasal septum over here. So this area forms the pedicle. So in any surgery, when you're talking of reconstruction, we need to preserve this pedicle. Like a
Yes, yes, sir.
single blood vessel over here, it is multiple sort of an arcade of blood vessels. So you have to preserve the maximum pedicle. That's why when we take an incision for Hadad, we take an incision right at the choana and come down this way. Okay.
Yes, yes, sir.
Starting from the lateral aspect of the choana, turn around, come down like this over here. Okay. Till the choana, this end. Then from here, what we do is we come forward onto the floor. This is the septum, this is the floor. We come down like this along the floor of the nasal septum, all the way anteriorly over here. All right. Now, if we
Yes, yes, sir.
the flap, we can extend this incision going down like this and include this entire floor as well, right? So we generally take our incision away, that suffices. But if you want a very large flap, you can include the floor nasal mucosa as well, okay? Mucoperiosteum over here. So either which ways, you come down up to the anterior end of the turbinate over here, correct? Now here, I also told you that this is the area of the cribriform. So the cribriform area starts after the attachment of the axilla of the turbinate here. It starts
Yes, sir.
anterior. This is all not cribriform.
Olfactory epithelium.
So this is all olfactory epithelium starting from posteriorly. And if I look into this area, there's a little bit of mucus getting in our way. 1 second. Give me a suction. So if you look at that, that's the area of the cribriform, which has the olfactory mucosa. Okay. I'm just going to look into that area here. So in CSF leaks, what we do is we gently move this here. We're not moving it actually. We're just keeping some pressure on this because the area there is hardly 4 millimeters. And we try to look into the area of the cribriform. Is the light maximum? Make the intensity 90 or 100. Okay, so I'm just showing you this area here. This is the region of the cribriform, and all this will be olfactory fibers, right? So
Yes, yes, sir.
in taking the uppercut is, I'll just show you. So the uppercut of the Hadad, what we do is we stick down and take it at the level of the inferior aspect of the ostia here. Okay? Start
Okay, sir.
laterally and then come like this. And when we come onto the septum, we maintain almost a horizontal trajectory, not exactly horizontal, just a slight upward trajectory. If you see here, there are vertical fibers over here. Can you see that?
Yes, yes, sir.
All olfactory fibers, whereas here you can see a lot of horizontal orientation. So you can
Yes, yes, sir.
target this area from this area, visualization, okay? So you take your incision something like this and come almost up to the anterior face of the
Middle terminate.
okay,
Middle terminate.
middle turbinate here, almost up to the anterior face here. So what this does is it preserves the mucosa for olfaction, one. It preserves the area of Hadad flap, that is the pedicle of the Hadad flap, before you go about whitening the sphenoid ostia. If I take a punch now and bite it down here, I'm going to be damaging this vascularity. Before I do anything for the sphenoid ostia, I need to take this incision, shift this mucosa on, and then do everything for the sphenoid ostia. So that's the importance of this area. It contains the vascularity for the Hadad flap. We'll go back
Yes.
into it a little later. Right?
Yes, sir.
Yes,
Yes.
yes, sir.
Coming back to your uncinate over here, you've seen the uncinate. Give me a backward biting forceps. So what we teach you is retrograde method of uncinectomy. Okay.
What is the direction of forceps, sir?
Yeah.
Backward biting forceps.
For the junior people, you saw me
Yes.
go, come back out, follow your instrument going in. Don't keep your instrument here and try to push your instrument. Okay. I'm not going to push in this instrument without seeing. I need to come back out because my instrument otherwise going to cause a lot of trauma. So I need
Yes,
to
yes,
come
sir.
out, take my instrument with a closed blade, go into this area like this. Once I go into this area, I open this blade, turn it around laterally, and then go about punching it. Can you see this now?
Yes,
Yes, sir.
What is the direction, sir, here?
Direction is exactly, see this. I'm taking it, turning it horizontally. And
Laterally and inferiorly, sir.
yeah. So this is the direction. Okay.
Yes, yes, sir.
Almost horizontal. It's not biting as effectively. If you have another one, give me that.
Is this, sir, accessory ostia?
1 minute, I'll come to that. No, that's not accessory osteas yet. So
Anteriorly, sir.
no, I've just made an incision over there. I mean, I've put a blade over.
Okay. Okay, okay, sir.
So here you see, I'm going back with this and making an incision over there, or I'm cutting the lower end. Give me a ballpoint probe. So here it was not biting as effectively, but you can see there is a small bite over here. Can you see that?
Yes, yes, sir.
Okay. So if you bite effectively here, I'll just do this with another instrument maybe because the backward is not working. The minute you do that, you've taken a cut. You've divided the uncinate into a lower limb over here. Can you see this lower limb over here?
Yes, yes,
Yes, sir.
This is the upper limb over here, correct? So
Yes, sir.
what you really want to do is you want to create this incision. With the backbiting, it was not occurring. I'm just moving it around to show you the whole area. Okay. Yeah, give me a debrider. And next thing I want to do is I want to take out this uncinate. See this? I showed you.
Yes,
If I just put my instrument here, I can do the same thing. But if I do the same thing here, I've created here a complete amount, see, my uncinate is already out over here, correct?
Yes, sir.
yes, yes, sir.
Safer way to do it is to come from here because by doing this, if I enter the orbit, I'm a dead man. I mean, not a dead man, but I'll be damaging the fat unnecessarily. So once
Yes.
I do this, yeah, where's the foot pedal? Give it on my left, right? So I take this. Again, if you see my debrider blade, my this thing blade is completely in my view. Okay, can you all see this as junior people?
Yes.
Yes, yes, sir.
Hidden. My blade has to be completely so I know what is cutting, and then I start cutting. Suction is not working on this. The suction is not working on this. Yeah, now it's working. Thanks. So you see this? I start debriding this uncinate. Can you see that?
Yes, yes,
Yes.
sir.
And you have to supposed to take the whole uncinate going superiorly all the way. You see the blade is always in view, and I'm going right up to the top end of it, right?
Yes, sir.
So many people don't go right up to the upper end and sort of leave it. Now, once you do that, what is the lateral part over here? It's all going to be the orbit. All right?
Yes, sir.
Give me a ballpoint probe now. Again, here, what I'm showing you is people talk of doing various procedures, right? What you can see a maxillary ostia coming up here, right?
Yes, sir.
Here, it uncovers because it's opened up the hiatus seminiolaris and the infundibulum, and you straight have an access with a 0-degree endoscope into the maxillary ostium. I'll show you that. Coming back to this, finishing this uncinate, you see this uncinate has a lower edge over here, which I've not taken off, right?
Yes, sir.
What they do is they take out the bone over here and sort of reflect this mucosa back onto the sphenoid ostia. Not really necessary. I'll just show you what I do. They call that as uncinoplasty, but that's not really required. what we do is we take out this lower edge of uncinate as well. Okay.
Sir, what is the ideal size of enterostomy?
I'm coming to that. Okay. Give me a 70-degree scope if you have. Okay. So now your uncinate is completely cleared off. Okay. Now I'm going back. I can see the maxilla with a 0-degree, but I still show you better things with a 70-degree. Okay. Just hold on. 70, 45, whatever you have. So all the junior people, you can see the, give me a curved suction. You will be able to see the maxillary ostium even with a 0-degree. But here I'm showing you the anatomy with a 70-degree with a purpose. Okay. Give me the ballpoint probe. Okay. So coming back to this is all the lateral wall of the uncinate. Can you see this area?
Yes, sir. Very well.
Area is nothing but the orbit. That will be the orbital plate down there. My ballpoint is not as curved, but here this is the area of the orbital plate. Okay, what you can
Yes,
see
yes, sir.
down here is nothing but the maxillary ostia. Can you see that
Yes,
sir.
yes, sir.
ostia here? If I move this endoscope here, can you see? Look inside the maxillary ostia.
Yes.
Little bit, sir.
Yeah, you can see it quite clearly.
Yeah.
I'll move it. I'll show you the whole maxillary sinus if you want. I'm showing you the ostia right now. I'm not showing you the sinus.
Right, sir.
Yes, yes, sir.
Correct. So what I want to show you is that this maxillary ostia is covered over by membrane anteriorly. Okay, mucosa. Give me this thing 0-degree. Whose phone is it? Who's getting? Forget it. Okay. So here you see this is maxillary ostia over here. Now you have to widen this maxillary ostia. I was asked, how much will you widen this maxillary ostia? Can you see the soft area over here?
Yes,
sir.
sir.
You also see this anterior part is a little soft before you hit bone. Okay.
Yes, sir.
Yes, yes, sir.
Ostia, you should not widen too much anteriorly. Most of the ostia you have to widen posteriorly.
Posteriorly.
All right. So when you come anteriorly, give me a 0-degree endoscope again. When you see the maxillary ostia needs to be widened depending upon the pathology. Okay. Now, for example, I just have a little bit of a fungal ball over there. Suction. I have a little bit of a fungal ball over there, right? I open up the uncinate process. I just suck out the fungal ball over here and my work is done. I can already look inside the maxillary sinus. Can you see that?
Yes, sir.
Endoscope. So I just suck out the fungal ball, end of story. Correct? On the other hand, I want to do a polyp surgery. Okay, polyps coming from the ethmoids. I want to do a polyp surgery. Do we have this or we have any other blade? 40-degree blade you have? Give me a 40-degree blade. So if you want to do a polyp surgery, we require a little wider ostia because we really want irrigation fluid to go into all the sinuses. Correct? So in that case, I would widen the ostia a little bit more posteriorly. On
Yes.
some other cases, like I'm saying in tumors, like angiofibromas or like inverted papillomas, in these cases, you require to inspect this cavity, right?
Yes, sir.
In those cases, I will create as large a middle maxillary antrostomy or maxillary antrostomy as possible, right?
Okay, sir.
Zoom out. I'm going closer for a reason. Give me a 40-degree. You want a demagnified picture, is it?
No, sir. It's okay, sir. It's fine.
So here, when I go onto the anterior wall, you see what I'm doing? I'll just take this and I'll take out a little bit of that redundant mucosa over there. I'm
Yes.
not widen it too much anteriorly. Can you see this?
Remove
Yes, sir.
without pressure, sir.
Yeah, completely. Once I managed to touch bone, I've stopped.
Yes. Don't give pressure. Yes. For junior.
Or this, you can see this area. So I don't mind widening this area. Can you see this area?
Yes, sir.
Yes, sir.
So it's not sucking. It's not cutting also. Okay, anyway, let me see. Don't worry, it'll be done. So here we'll take this, we widen this maxillary ostia going posteriorly, right?
Yes.
It's not cutting effectively.
We can cut with true cut forceps, sir, also.
But they don't have, the true cut is not Let me try with this. Suction को powerful कर दो, please. Suction is working. Suction बंद किया है क्या इस पे? It's not cutting at all. Just give me the 0 degree blade. Doesn't matter. Give me the 0 degree. 0 degree was at least okay. 0 degrees दे दे. चलेगा. So you see, as we keep widening it a little bit, you're seeing more and more of the maxillary sinus, correct?
Yes, yes, sir.
Hope in the meantime. Now remember that
Sir, how much posteriorly we can go to prevent injury to the spinopalatine?
I'm coming to that. So here you see, this is the upper end of the inferior turbinate. Can you see that?
Yes, sir.
The inferior turbinate, and this is the upper end. So your maximal antrostomy can go down up to the upper level of the turbinate.
Yes, sir.
Here, as you go, you will only remove all the soft tissue. You don't go and hit the bone. Posteriorly, you have the perpendicular plate of the ethmoidal bone. Okay, sorry, palatine.
Palatine bone.
Yeah,
Yes, sir.
you will not be hitting that posterior plate of palatine bone. Yeah, this blade is.
Okay, sir.
So here you see, I'm only taking out all the soft tissue. Now you asked me about accessory osteum. Accessory
Yes, sir.
osteums are not in the front. They're mostly in this posterior area. Okay. If
Okay. Posterior fontanelle.
yeah, posterior fontanelle. So if you get an accessory osteum over here, you need to combine the anterior and the posterior fontanelle. That is the natural ostia and the accessory ostia, so that
Yes,
there's
sir.
circulation of the fluid or the mucus inside. Okay.
Yes, sir. Yes, sir.
I told you that the size of the maxillary ostia will depend upon what is your pathology. So
Yes, yes, sir.
you don't really require to widen the maxillary ostia in this way. I'm just
Yes, yes, sir.
demonstration. This is the maximum limit which you can go. You see that? Now my
Yes, yes, sir.
now my instrument is touching on bone. Can you see that?
Yes, yes, sir.
Like that. Similarly, superiorly over here, what you can see, you can just see I'm
Orbit.
fossa, but you can just start seeing the region of the
Orbit.
orbital floor.
Yes, yes.
Right over here. So you already have a very nice big view into the maxilla. And here, the maximum extent you can go is here onto the superior aspect of the inferior meatus here. If you debride too much over here, your inferior meatus will sort of start oozing. All right?
Yes, sir.
Inferior turbinate, sorry. So here you see, you can see almost the entire maxilla with a 0 degree endoscope. Can you see that?
Yes.
What is the other thing you cannot see with a 0 degree endoscope is your anterior wall or your floor, right?
Yes, sir.
That if we have, do we have a 45 or a 70? Whatever. 45 there. There you go. So there are different ways you deal with pathology of the maxillary sinus. Okay, I've just shown you still only maxillary sinus. I've not gone to any other sinus. I'm just showing you everything related to maxillary sinus. So again, I repeat, for fungal balls or for just simple maxillary openings, do not need to widen the ostia. But depending upon your pathology, you can widen it to the extent desired. Okay. Now coming back to this, I'm using a 45 degree endoscope. With this, I'll start looking more anteriorly or inferiorly. Can you see that? I'm looking now
Yes,
at the floor. At 6
Yes,
o'clock,
sir.
you can see is nothing but the floor of the maxillary sinus, right?
Yes, sir.
Yes, sir.
Antigerous cysts or anything of that sort over there, that 6 o'clock position would be the area you really want to inspect. Correct?
Yes,
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 sir.
sir.
Now I'm turning my endoscope a little bit more. I can almost see the anterior wall. Okay. Just about there, you can see to the left, that is the area of the 9 o'clock position. You can see the anterior wall. Correct? Now, what
Yes, sir.
who is operating in that area? Suppose I have a lesion where I need to really look at this area. Give me, you have a really curved instrument? Give me a curved instrument.
Can you show us the anterior wall, sir? And if prominence, then infraorbital now.
Yes, I'll show you everything. So here you see I'm going almost up to the anterior canal. Now my instrument is not as curved, okay? But there you can see the, can you see this
Infraorbital nerve.
Bulge of the infraorbital
of
nerve.
the infraorbital nerve? So that's
Yes,
the
yes, sir.
and what you can see at 9 o'clock position is nothing but the anterior wall, right?
Yes,
Yes,
yes, sir. Yes, sir.
Assume, I've shown you this, assume I cannot go into the maxillary sinus. So what do? I have got a lesion there. I need to remove it completely from the anterior wall and I don't have my access there or I don't have an instrument to go in there, correct? Then what do? Give me a 0 degree endoscope. So again, with a 0 degree endoscope, I don't have anything at my disposal. I'm stuck. I really can't go into the anterior wall. I need to look at the anterior wall. What are my other options? I'm going to show you. Okay. Give
Yes,
me
sir.
a. So here I have an option of going into the inferior meatus over here. Can you see this?
Yes, yes.
Yes, sir.
Told you the nasolacrimal duct is anteriorly. Go and palpate the softest part of this inferior meatus. Okay,
Okay.
just a little behind the nasolacrimal duct. Palpate it, and when I go into this area over here, you see this? I will just sort of palpate, and then dip my instrument into that area. Okay, this is the soft part. I'm going to go into this area over here. In this specimen, there. It's already gone in. And what can you see? You can see my instrument coming out there, right?
Yes, sir.
So this is posterior to your nasolacrimal duct opening. You can see my instrument from the inferior meatus has gone into the maxilla. Correct? Now, how does this help me? You saw I didn't have an instrument to deal with the anterior wall. I had only an endoscope, right? So now
Yes, sir.
2-degree endoscope. But if I really want to do something, for example, I want to debride, I can take an angled debrider, go through the same inferior meatus what I've done, take my debrider there and do whatever I want to the anterior wall or through the floor. Is this clear to everyone?
Yes, sir.
Yes, sir.
This is one option we have here to go through an inferior meatal antostomy and take a debrider and take out whatever you want from the anterior wall of the maxilla.
Okay, sir.
There's a
So what is pre-lacrimal approach?
I will talk about that again little later.
Okay, sir.
Okay, pre-lacrimal is ahead of the lacrima. I'll talk about that approach little later. Okay. So this
Okay,
is
sir.
thing. First, I'll show you what is basic steps of maxilla, basics of frontal, basics of everything. Then I'll come to pre-lacrimal, show you what is medial maxillectomy and other things.
Okay, sir.
So coming back to this area now, okay, you have widened the maxillary ostium to the maximum, right? Now here you're seeing again the bulla, right?
Yes, sir.
Yes, sir.
Here this is the inferior orbital wall. This is all the medial orbital wall over here, and that's
Yes, sir.
bulla. Okay, this is all bulla, and this is all orbital plate over here, just where my uncinate came off from, right? So people want to do a frontal sinus surgery, 70-degree endoscope. Let me explain to you what is frontal sinus surgery. Okay.
Are you always doing intact bulla, sir, for frontal sinus?
Good question. You're ideally supposed to do it. I won't lie. Every time we don't do intact bulla technique. Okay. Ideally, it's supposed to be done, and this is the correct way to do it. Once you gain an experience, you tend to move things very fast in a different way. You don't go sequentially. Okay. We all know that, and we have to be honest about that, right? So here
Okay.
you see, this is the anterior face of the bulla. Can you all see that?
Yes,
sir.
yes, sir.
Okay, that's the middle turbinate. That's the region of the orbital plate. Okay, or the lamina fascia. So you have the orbit laterally, you have the turbinate medially. This region is nothing but the frontal beak over here. Can you see that?
Yes, yes, sir.
This region? So wherever the frontal beak ends, you will automatically go into the frontal ostia. So if
Yes, yes, sir.
it is very thick, and there is the region of the frontal ostia. Can you see that straight away there?
Yes,
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 sir.
yes, sir.
There is this little piece of bone which I will take out, but you can already look into the frontal sinus there. So if
Yes, sir.
if you're lost, okay, remember there are a lot of configurations. I'll talk about how to go into the frontal recess, but by and large, you have to maintain these 4 boundaries. The anteriorly, the frontal beak, medially, you have the axilla of the turbinate, laterally, you have your orbital plate, posteriorly, have your bulla, and you go into this area there. You have to go into the frontal recess. So this is all
Yes, yes, sir.
over here, right?
Sir, what are the precautions to prevent post-op stenosis over frontal recess area?
I'm talking about that again. Now, just give me 1 second for this. Now, this is a
Okay,
small
sir.
cell. What is this cell? This is nothing but the agar cell. Okay, give me
Yes, yes, sir.
this thing 45-degree. Oh, 45 is not working. Give me 0. See if anything else is working. 45 would be ideal. No, no, no. The debrider blade, because it was not taking it 2 minutes ago. Whatever you have, as long as it's working, it's fine. So agar cells, give me a ballpoint probe, but till you put that, give me. So all the students remember there are a lot of things you'll have learned about frontal sinus entry, right? You'll have learned about agar cells. So this first cell that you see is nothing but an agar cell which I'm taking out, right? Sometimes your ethmoidal cells pneumatizing into the frontal recess in varying sort of anatomy. The frontal recess, all these ethmoidal cells itself pneumatize over there. Okay, you can have one cell deep or blocking the frontal recess opening. That's called the Kuhn type 1. You have
Yes, sir.
here, you have, it's called the Kuhn type 2. You have a cell going more than halfway up the frontal sinus. You call it Kuhn's type 3, and you have an isolated frontal sinus cell. You call it Kuhn type 4. All right?
Yes.
Theoretically, very good. But ideally, you have to maintain your boundaries well and then take out all the cells. So all these cells establish the drainage pathway for the frontal recess. So anteriorly, the agar, posteriorly, the ethmoidal cells, and the orientations. All of this would tell you where your frontal recess lies. Is this clear to everyone?
Yes,
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 sir.
sir.
Anyone wants to add anything among the moderators? Please go ahead. If there's anything that I've not told, please go about and explain the same. Okay. Now,
Okay, sir.
see, this is the frontal recess, right? And you're
Sir.
looking now into the frontal sinus. Can you see that?
Yes,
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 sir.
sir. Very clear, sir.
So can you tell us
What
about
is
the
the-
axillary flap and when do we do that?
Coming to that. Give me a sickle knife. So different types of approaches. Now you saw I went into it with a 70-degree scope. The axillary flap was designed. Okay, let me shift to a 0-degree scope instead. So axillary flap is done so that you can look into the frontal sinus with a 0-degree endoscope. Okay. Instead of using a 70 or a 45, you look into the frontal recess with a 0-degree endoscope. So what is an axillary flap technique? Give me a sickle knife. Is you take an incision like this, and like this, and shift this flap posteriorly. Okay.
Okay, sir.
Yes, sir.
Then you start exposing the frontal beak. You bite this frontal beak. Okay. And then you'll be able to look into the frontal sinus with a 0-degree endoscope. This
Okay,
is
sir.
by Peter Wormald. Then it was further modified by Richard Harvey, calling it Carolyn's window. So in Carolyn's window, what he does is he takes an inferiorly based flap, a flap that starts from here, goes up, comes anteriorly, comes down, takes this whole flap down to expose the
Okay.
face of the frontal beak.
Frontal peak.
So when you expose this frontal beak, you can have a head-on entry into the frontal sinus from here itself, rather than just bite the frontal beak. So there are two approaches here. One is the axillary flap technique, and one is the frontal beak technique. Axillary flap technique and the Carolyn's window.
Is there a definite advantage, like say when we talk of long-term outcomes of frontal sinus surgery, when we do an axillary flap or a Carolyn's window and then the frontal vis-a-vis opening up the frontal sinus from inferior aspect? I mean, does it improve the outcomes?
See, Yash, by and large, all these techniques have been described when you cannot identify the natural osteo or when you struggle to go from here, right?
Yes, sir.
The
Yes,
most
sir.
direct approaches, and sometimes we need to go very fast, like we're doing a draft type 1, 2, 3. Then we
Right.
need to go straight into, drill out the beak and do further procedures. So all these are procedures designed to deal with the frontal beak. By and large, in simple front fess surgery, we don't need to deal with this beak as effectively, so we don't need to touch this.
Yes, yes, sir.
If I'm doing a frontal type 2, 3, etc. Now I'll explain to you what is frontal sinus type 1, 2, 3. Okay. What I've done here is a frontal sinus type 2 opening here. Okay. Okay. Draft.
Yes, sir.
Frontal sinus here. I've done a draft 1 opening. Sorry, not 2. 1 opening here. Can you see this here?
Yes, sir.
Yes, sir.
Yeah. Clean the scope. Give me a 70-degree again. Let me just show them with a 70. I'm going to shift it again since I'm going to the draft procedures explaining that. Give me a ballpoint pro. Now clean it. So draft 1 means just clearing up some cells around the frontal recess without opening up the frontal recess. Draft 2 is what I've actually done. From the middle turbinate, I've taken it up to the orbit. Okay? Yes?
Yes, sir. Yes, sir.
This is draft 2A, where I've taken it from the middle turbinate up to the orbit.
Orbit.
Okay?
Yes,
Draft
sir.
2B, I would take it from the septum here to the orbit.
Right.
Septum to the orbit.
Orbit.
That is type 2B.
Yes, sir.
2A is what I've done. 2B, if I was extend this, I would drill this more going towards the septum. Okay, that
Yes,
is
sir.
draft type 2B. And if I repeat draft type 2B on both sides, that becomes draft 3, or it comes what is called as a modified endotropic MEL. That is the modified endoscopic Lothrop procedure. Is that clear to everyone?
Yes, sir.
Yes, sir.
So one thing is you must realize you need to preserve the mucosa of this frontal recess. If you damage this mucosa of the frontal recess, if you use a debrider over here, you see where I'm touching my instrument? If I use a debrider exactly at this area all around circumferentially, I may cause a stenosis of the frontal sinus. So when we
Yes.
remove cells, we only deal with one area over here. We are only removing cells. We are not drilling the edge of the frontal sinus ostia. Is that clear?
Yes, sir.
Yes, yes, sir.
I know I've gone into the frontal sinuses because this posterior edge is like a curved area. Okay, that's the frontal
Yes, sir.
lobe. So it gives you a sort of a curved area, convexity facing you. That's what the frontal sinus would look like. Is this clear?
Yes,
Yes,
sir.
sir.
Sir, what are the various ways to remove polyp inside the frontal sinus?
Boni?
Polyps, disease.
Okay, okay. I
But
just explained to you the simplest way. Now, polyps don't originate from the frontal sinus. They always originate in the ethmoidal cells and sort of block the frontal recess opening, so that most often you don't have polyps inside the frontal sinus. You have more or less secretions in the middle sinus. Suppose you do have polyps, they're all starting from its opening right over here. You have the opening over here. The polyps start over here. I mean, start from the ethmoid and sort of occupy this position. The minute you take it down, your frontal sinus recess is already open. All right. And if you have any disease like you have fungal sinusitis or you have inspissated mucus, etc., debris lying inside the frontal, we have to flush it out. Okay.
yes, sir.
Suppose this frontal
Flushing is very important in frontal sinus.
Suppose this frontal sinus, you can see my instrument is going there. Suppose there is a cyst lying in the lateral aspect of the frontal recess, right? So what are my options? Or suppose I have a mucocele. Mucoceles you can drain directly through the ostia, but more importantly, if you have cyst or this frontal sinus has a disease and I have to go and go to the most lateral extent of the frontal sinus, what do? I have the options again, like I told you, I can do an endoscopic draft type 2B. I can do an endoscopic type 3 if it involves both sides. Okay, draft type 3, or I can do an external approach. An external approach would be a direct access through this eyebrow incision. Correct?
Yes, sir.
So don't discount external frontal sinus surgery incisions. Is that clear to everyone?
Yes, sir.
Okay. So now here you have the maxilla and you have the frontal. So I'll talk about again basic fes and then I'll go on to other things. Okay. So here you see this is the bulla. Give me a 0-degree endoscope now. You want to figure out where is the anterior ethmoidal artery, right? 1 minute.
Yes, yes, sir.
Okay, let me use this only for the time being.
Everyone has a fear of anterior ethmoidal artery in face.
So what I'm doing is, whenever you have a bulla, again I'll use a 70-degree endoscope and show you, so I can show you everything on the anterior aspect. It's just getting a little fogged because of the mucus and hair over here. It's okay. Chal. So here you can see that the bulla has gone right up to the skull base. Can you see that?
Yes, sir.
Just behind it. So when the bulla goes onto the skull base over here, the anterior ethmoidal artery is covered in this bulla or is protected by this bulla. Is this
Yes, sir.
everyone?
That is the advantage of intact bulla technique, sir.
If there is a suprabullar recess here, then your anterior ethmoidal the bulla does not go right up to the skull base. You have a space over here called the suprabullar recess. All right. Now give me
Yes.
Yes, sir.
same way. I will show you what is orbital plate and orbital this thing supraorbital cell. Okay. So here I'm just going in here. I don't have the correct debrider blade, but let me see if I can show you. नहीं कोई बात नहीं चलेगा. So I'm just going to debride a little bit over here. I'm entering the anterior ethmoidal cells over here just to show you how the anterior ethmoidal artery is protected. It's not debriding. It's not debriding. Yeah, what is this? What blade is this? Give me anything that cuts or see, make sure that the suction is working. नहीं इधर कुछ नहीं हो रहा है. Okay, छोड़ दे. I'll just break it up. Don't worry. रहने दे मित्र. रहने दे. So I'm just opening up this for demonstration. Okay. Okay. Now what am I trying to show you through this demonstration? Give me a ballpoint probe now again. Here You can see that's the orbital floor, right? You can see I've gone into this area. Can you see this?
Yes, sir.
Okay. And you can see something else over here, right?
Yes, sir.
What are cells and what is of this area here? Okay. Can you see this here?
Yes, sir.
Cell. Can you see this?
Yes, the supraorbital cell.
These are all cells. This is all the frontal recess at the posterior wall of frontal. I've just opened up the anterior face of the bulla and I'll just go inside and show you more cells. So everything looks dangerous to start off with. But
Yes, sir.
once you clear up the cells, if you're worried about using a debrider, use a simple instrument, okay?
Yes, sir.
This debrider was not cutting, so I could not expose this area better. But here now, once I expose the skull base, okay, I'll show you what I see. So with a debrider blade, I'm going here. Now for the junior people, don't go with a debrider blade if you're not comfortable. So I'll show you what you have to do with a 45-degree forceps. For the junior people, maybe you can use, or give me a curate. Curate hai? Now give me a curate. I'll show the junior people how it's to be done. Curate nahi hai? What else will you give me? अच्छा दे दो. जो भी है दे दो चलेगा. So what we'll do is I'll use some other instrument since we don't have a curate. I'll use some other instrument and show you. So you just go like this and clear these cells from back to front. Can you see this here? Okay. And I clear these cells like this. Can you see this here?
Yes, sir.
Okay. So once you clear these cells, what are you exactly trying to look at? You're trying to look at the anterior skull base, right?
Yes, sir.
Okay. Now give me a 45-degree endoscope. We don't have a curate at all, is it? Okay, give me the debrider. Let me finish this part first. कोई बात नहीं, कोई बात नहीं. I wanted to show them with a curate. Okay, what I'm showing you is to be done with the help of a curate. Okay. For all the junior people, don't use a debrider at the skull base because you never know how you can hurt the anterior ethmoidal artery. So here,
Yes, sir.
don't have a curate, so I'm using my debrider blade. But I'll just expose a few things and then show you what's to be done.
Always work in the middle to prevent retraction of artery if it injured accidentally.
Correct.
It is better to work in the middle.
Yeah. So now we are at the skull base, all of this. Can you see this? How do I know
Yes.
the skull base is because one, you have the color change, and two, you'll be able to follow the skull base from the front to the back. So this is the posterior aspect of the frontal recess. Okay. One cell over here, maybe here, and right behind that one cell, what you will see is an anterior ethmoidal artery over here.
Yes.
Yes, sir. Very nicely seen.
So always this cell is called the supraorbital cell. Sometimes it pneumatizes and goes over or above the orbit where it goes very deep. It can form a supraorbital cell. Otherwise, sometimes it ends as a small sort of a cell here itself. And that's one cell behind the frontal sinus. The frontal sinus, one cell behind, and then you have the anterior ethmoidal artery.
Artery.
Yes, sir. Sir, is there a space between skull base and anterior ethmoidal artery?
Any?
I think there is a space between skull base and anterior ethmoidal artery.
What I showed you.
Can you pass the ball probe behind the artery, sir? Superior to the artery?
I'll do that. Okay, so I was trying to say that you have to be careful not to use a debrider there for this very purpose. You see here, many a time the anterior ethmoidal artery is within bone, but here you see the anterior ethmoidal artery is sometimes open. So if you use a debrider over here and you don't realize it, you're going to catch on to the anterior ethmoidal artery. Correct?
Yes. Yes,
So
sir.
now, if you do catch on to the anterior ethmoidal artery, what are your options? One is you can take a bipolar, keep your endoscope the way it is, keep a suction so that the blood, give me a suction, straight suction. Keep a suction there. Okay, someone has to hold a suction there, identify it, and then use a bipolar and sort of buzz it off. Okay, so you take a suction, keep a suction over there so that the blood goes into the suction rather than onto your scope. See the bleeder and then bipolarize it. Suppose it retracts, then what happens? It goes straight into the orbit. Now I'll show you the anatomy of the anterior ethmoidal artery also again little later. Okay. So coming down to again the other parts. Now give me a 0-degree endoscope. Is that clear how to manage the anterior ethmoidal artery?
Yes, yes, sir.
I'll show you all the extended procedures of frontal sinus as soon as I finish this. These are the basic steps for the juniors. I'm going first.
Yes, sir.
I show them everything, they will get confused. So,
Hello.
Yeah, hello.
Sir, what about in such some patients, frontal sinus is not developed,
Yeah,
but
so
it is very small. How to locate or
it's okay. You can see that on the scan. Everything is to be studied on the scan preoperatively. Okay. If it is small, if there is agenesis, if there is hyperpneumatization, everything is to be studied on the scans. Okay. Now, the other thing what I want to show you is here, these are all the posterior ethmoidal cells. Now, posterior ethmoidal cells are not so pneumatized. Although you sometimes see a big bulge over here, correct? So, what is the easiest point of entry is here. This is the region of the ground lamella, almost there. Okay. What is the ground lamella is the region. Give me the ballpoint probe again. Ballpoint probe. Here you have the turn of the turbinate. Can you see that here? So roughly at the turn of the turbinate, there'll be a plate of bone which will divide the cells into an anterior ethmoidal cells and posterior ethmoidal cells.
Yes, sir.
Now, what I'm doing is I'm going to show you the easiest point of entry is here. Correct? See that? Can you see that? Anteromedially. Here. I can widen this over here by opening up the ground lamella. I can widen this frontal, I mean the posterior ethmoidal sinuses. I've finished with the anterior ethmoidal sinuses everywhere, little bit on the anterior part left, but here all this is posterior ethmoidal sinuses. Okay, I've gone through the ground lamella. Correct. This debride is not very effective. Now, one thing you must understand is I'm showing you this again here. Okay, you have to go very carefully. Give me a curate, nahi hai na? Give me a ballpoint probe. So if I had a curate, what I could have done at this point in time is I could go like this behind these cells and fracture these cells forward. Can you see this?
Yes, yes. Fractured anteriorly. Yes, sir.
One safe technique is to fracture these cells forward. So if I have a curate, I just fracture these cells forward. Now just to
Yes,
save some time, I'm going to debride it. Okay. So debriding means you're going front to back and curating means you're coming back to front. It's okay. Don't worry. Don't worry, Weber. Tension नहीं है. Weber, रहने दे. कुछ problem नहीं. हो गया almost. That's okay. It will come of use later. है तो ठीक है, नहीं है तो भी ठीक है. Okay? So I'm going very close to the anterior ethmoidals there. And what I've done is I've gone into this posterior ethmoidals over here. Correct? Can you see that?
yes, sir.
So maxilla and posterior ethmoidals. Now, where does my sphenoid come? Am I into the posterior ethmoids? Where is my sphenoid? These are all the questions in the juniors' minds. Correct?
Yes, sir.
Okay, good. So now what I'm going to do is I'm going to show you how to go into the sphenoid. So there are various techniques described. One is once you reach your posterior ethmoids, you have to go here much more medially and inferiorly. Can you see this?
Yes, sir. To
Much
find the superior turbinate.
Yes. So you go into this area. So there are three ways to go into the sphenoid sinus. One is the medial technique where you have a direct access into the sphenoid. Now give me a suction. Okay, I've just moved the superior turbinate here. Give me a suction. I'm just going to go into this. So many a time you can see the ostia. Many times you have to make a hole into the ostia. Can you see that? I've just gone
Yes, sir.
into the ostia. Correct?
Yes, sir.
Okay. Now, whenever you have to widen the sphenoid ostia, you don't widen it downwards. Okay. I've just used my suction to create that opening there. Can you see that?
Yes, sir. If you want to widen the downward, then what to do, sir?
Yeah, I'll just explain that again. I already explained, but I'll explain again. So here you see I've identified the sphenoid ostia. This is the medial approach. The intermediate approach is when you go here. Give me a Freer's elevator. Go here. This is the horizontal. Can you see this? This is the horizontal limb of the middle turbinate.
Yes, sir.
Behind this horizontal limb of the turbinate, you go and make an incision over here, and then you identify the superior turbinate. Okay, give me a debrider. No, I don't. Okay, yeah. So you go into this posterior half. Okay, give me a debrider. I'm just taking out this excess mucosa over here. And what you do is you go and identify your superior turbinate.
Yes, sir.
You'll be able to see your superior turbinate and then on the sphenoid ostia. So that's the second way, or what we call the intermediate approach. Okay.
Yes, sir.
And third one is a medial approach, is where you have to go directly into this area over here. Okay. From anteromedial, this area, you can identify that directly. I'm just opening up this area better for you. That's the superior turbinate. Can you see that?
Yes, yes, sir. Sir, how much part of the superior turbinate should be removed?
Only the inferior parts. If you can manage it without the inferior part, you don't even need to remove the inferior part.
Okay, sir.
Okay. Is to uncover the ostia. So Weber was asking reason for removing the inferior 1/3 is because you don't superior 1/3 of 2/3 of the
Olfactory neurons
fibers of
are there.
olfaction. Okay. Contains some fibers for olfaction. So
Yes, sir.
is the superior 2/3 of the superior turbinate.
Yes, sir.
Yes, you want to add anything?
Sir, Hitesh here. Yes, he's just outside.
Who's standing? Yes, that
Hitesh, sir.
you can add. Hitesh sir has come.
Sir, Hitesh is here only, sir.
Acha.
I'm here since beginning, sir.
Oh, okay. Okay. I thought you were not supposed to come today.
No, no, sir. I'm here from beginning, sir.
Okay. No, I thought it was you, but for a second I was wondering with someone else.
No, no, sir. Yes was there, but sir, yes was just outside for tea.
Oh, great. So here, this is the superior turbinate. You can see through a medial approach. I already showed you how to identify the sphenoid sinus. Here, you can see through the intermediate approach to identify the superior turbinate, and you can see the sphenoid sinus. But in a medial approach, you would go from the posterior ethmoids anteromedially, okay, or inferior
Yes, sir.
over here, and then go into the sphenoid sinus directly through this approach. So 3 approaches for that, right?
Which is better according to you, sir?
Whatever is convenient. If there's a definitive, if a junior wants to identify this is the easiest approach, this or going through an intermediate approach. Okay.
Yes, sir.
This approach, you have to be careful when you get an onodi cell. So what
Yes, sir. Yes, sir.
thing called the maxillary line. What is the maxillary line is? Take this line drawn from the base of the orbit here, going like this up to the sphenoid, right?
Yes, sir.
Here.
So,
See below this line. So
yes,
once
sir.
you get below this line, you have to identify your sphenoid ostia first. You can see that over there? Sphenoid
Yes,
ostia
yes, sir.
first. I'm just moving it with this thing. Give me a debrider. Let me open it up. I'm removing the lower 1/3 of the superior turbinate. Hitesh bhai, good to have you. Huh? I really thought you're not coming today. I was told.
No, no, sir. I am here only, sir, since morning.
Yeah. No, I heard your voice. But
Okay, sir.
since I was told you're not coming, I thought it is someone else's voice.
No, no, sir.
ठीक है. तो आप बोल सकते हो if I'm missing out on anything. Okay.
Okay, sir. Okay, sir.
To show anything different or any different sequence, let me know. I'm deliberately going slow for the juniors
Yes, yes, sir.
because I think that is what they all wanted, right?
Yes, yes, sir.
Basic tests, how to do it without causing problems.
Yes, sir. Without complication.
Correct. So here you have the maxillary line, and maxillary line here, if you stay, you identify your sphenoid sinus. Can you see this here?
Yes, sir.
From your sphenoid sinus, when you come anteriorly, okay, you take out all the cells which are already took out, then you're unlikely to cause any damage to the onodi cells or anything else.
Optic nerve.
You're staying on the anterior wall of the sphenoid sinus, your vital structures like optic and carotid are never going to get injured. So that's the reason
Yes.
by this area and stay with your debrider better than this area. However, as seniors, we all go and do things variously, as I told you. Okay, you just need to be careful about what you do. Again, for the junior people, if you see, I can easily crack cells. Can you see this? I can crack any amount of cells. Can you see that?
Yes, yes, sir. Very nice, sir.
Go to the skull base, you'll be able to hit on hard bone. This is hard bone over here. Can you see this?
Yes, sir. Yes, sir.
Once you identify your sphenoid sinus, you can remove the party wall between your sphenoid sinus and your posterior ethmoids. Can you see this?
Yes, sir. Yes, sir. Very nice, sir.
That becomes then a safe thing because then you're sure you're not hitting on an onodi cell.
Yes, sir. First, identify the sphenoid ostium is better.
Correct.
Then do the posterior ethmoidal work.
Correct. So now I don't mind doing this. My debrider is not that. Okay, it's going. ठीक है. कोई बात नहीं. So you see over here, this cell tract was hidden behind, right?
Yes, sir.
But I didn't approach that cell tract before. Give me a forceps. I didn't approach the cell tract first. I did the sphenoid, identified the anterior face of sphenoid, and then I'm going to remove all the cells anterior to it. Correct?
Yes, sir. Sir, please explain the inferior border widening of sphenoid.
Yeah.
How to prevent injury to the septal branch.
I already said that in the beginning of the. I already said that right at the beginning. But I'll just show that now. Okay.
Yes, sir.
I'm just clearing off all the cells. Just as in master, you take out every damn cell. You really want to clear out the cells over here. Okay. Now coming back to this area, you see over here, some amount of cells still here. You can take out these cells. But as you start going back, for the junior audience, it may be a better idea to use a curette rather than to use this debrider. Debrider is a powered instrument. Okay. Well
Yes,
done,
sir.
in experienced hands, but you don't want to go there and catch hold of a decent optic or a carotid or whatever may come over there.
Sir, how to differentiate between onodi cell and sphenoid sinus?
Yeah. So again, that bone chip over there. So again, that I told you is your part of studying your scans pre-operatively,
Yes, sir. One thing is can. Okay, sir.
both on your
Another-
corners as well as axials, and even your sagittals will give you an idea of what your onodi cell is. Okay.
Yes, sir.
So I already told you by sticking to the anterior wall of the sphenoid, you're going to prevent injury to the area of the optics. I'm just
Yes, sir.
a little bit for you. Since
Is
it-
there any, sir, change in the shape and direction?
so it looks more triangular and it sort of goes towards the orbit, okay, the optic nerve.
Yes, sir.
You see, I'm into my sphenoid sinus over here. All right, some amount of septations here. I showed you this sphenoid from here, and I'm showing you the same sphenoid from there as well, right?
Yes, sir.
I'm just clearing out some cells and mucosa. And you see how the posterior cord smoothly leads into the sphenoid, right? You remove
Yes, sir.
the wall and they almost look like unition. I'm just going to remove all this party wall in the middle. I'm using a debrider because I have the luxury of remembering this is a cadaver. But please, junior people, take care, okay?
Yes, yes, sir.
Go
True,
all
sir.
accurate. Okay, we halt here. Now give me a Q. Oh, we don't have a curate again. So coming back to what is your skull base, give me a 45-degree endoscope. So many a times juniors are asked this question, why would you do a full house fest? Okay. What is a full house fest is what is a question asked and why would you do a full house fest? Suppose a disease like polyposis is not involving the frontal recess. It's only on the ethmoid. Will you do a full house fest is a exam question, right? This lens is good, I think. A lens like periphery देखो 45-degree. It's not clear. It's give me a 7. ठीक है, let me show it quickly. नहीं, focus है क्या? नहीं. Okay, ठीक है, चलो. Give me a suction, curved suction दे दे पहला. So I'll explain you the concept again, okay, of when to do what type of surgery, and then we'll go
Yes,
into all the extended surgeries. So here, I've already showed you. This is of course I have a 45-degree. You're seeing the frontal recess over there.
Yes, sir.
You're seeing I'm not damaged anything over there, and I've come into this one cell over here.
Okay.
Maybe
Sir, is it necessary to remove that septa?
this, yeah, it's a good idea
No,
to,
no, sir.
but not form
Just
septum.
superiorly, sir. So just superior septa. This
No.
one.
This you can remove. That's not a problem. But
Okay, sir.
hard, don't try to push on it. If it's a soft septa, break it. If it's
Okay, sir.
not a bone, don't try to do anything because then that leads to severe stenosis. Like here, I would like this to be smooth, but this is almost flush here. Can you see that?
Yes, yes, sir.
So soft cells you can remove with a suction. Hard bone, don't try to meddle and remove it. I don't want this to look like an expressway. I'm more interested in removing the cells.
Yes, sir.
Everyone? Okay.
Yes, clear, sir.
This is, for example, a hard bone, right? I
Yes,
don't
sir.
make this flat. I cannot make it flat like the anterior and posterior part of this.
Yes, yes, sir.
I'll remove these intervening cells which are easily dissected off over here. Can you see that?
Yes, 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 sir.
This is your face. This is your anterior ethmoidal artery. Okay, over here,
Yes, sir.
anterior ethmoidal artery, and this is all your posterior ethmoids all over here, going completely towards the sphenoid down there. Can you see that?
Sir, yes, sir. Sir, how many times you encounter middle ethmoidal artery?
I have not encountered it as yet, luckily, but I've got a picture of how do you do it. Now coming back to anterior ethmoidal artery bleed, since we are there, let's talk about it. Everything
Yes, sir.
later, then I'll only forget. Okay. So Akshada, you're laughing. Okay. My fellow Akshada is smiling. Okay. So this is the anterior ethmoidal. I told you if you do damage it, take a bipolar and buzz it right here and there. In certain situations, we bipolarize this deliberately, like in transcribiform approach. I want to take this anterior ethmoidal artery, cut it off, identify the posterior ethmoidal artery, cut it off, and resect it. Okay, to get a place between that. So in some cases, we always cut it. Okay,
Sir, why not to use unipolar?
unipolar, I'm not in favor of, because sometimes this is attached to the skull base. You can cause CSF leaks. Okay,
Yes, sir.
hanging down.
And
But-
also current can pass to the brain.
Correct.
It's unipolar. Yeah.
Correct. So ideally, I don't like. Ideally, you take a bipolar and bipolarize this. Now, suppose this artery retracts and goes into the orbit. You have not had time and it's already gone. It goes straight into the orbit. Then what do? You would then go about and do a medial orbital decompression, right?
Yes, sir.
And in the lecture, so we have all heard of. Give me a forceps. We have heard of lateral canthotomy. Okay, removing the lateral canthal tendon. But how many of you all are able to do a lateral canthotomy, right? And
Yes,
by
sir.
the time you call the ophthalmologist, you are in trouble. Because
Yes, yes.
well. So the minute this retracts, one of the first things that you can do is
Orbital decompression medially.
yeah, exactly. So here, no, give me a Freer's elevator, please. So here, this is all your orbital plate here. All this laterally here is your orbital plate of bone. Can you see that?
Yes, yes, sir. Clear, sir.
The minute you see a bleed, what you have to do is take out this orbital plate of bone. This is all lamina pepricia, what you're seeing here.
Yes, sir.
Lamina pepricia. Okay. Open up this whole area so that the eyeball gets some place to
Shallow.
swell. Is that clear to everyone?
Yes, yes, sir.
Okay. Now, the other thing is once you do this, you can even take cuts on the orbital periosteum so that you're allowing your fat to prolapse out.
Okay, sir.
So you can do that. And then if necessary, you can do a lateral canthotomy.
Yes, sir.
So now you can see all this is lamina and that's the orbit. Can you see that?
Yes, yes, sir.
Okay. Now give me another forceps. So that is why I told you, you have to understand the limits. Suppose you do damage this orbit. Okay. Now I'm just showing you deliberate opening of the orbit. No, I want an angled forceps if you have it. If you do damage the orbit, okay, orbital plate, nothing to worry. You can see my orbital periosteum is intact. Can you see that?
Yes, sir.
Orbital periosteum is intact. Correct? Give me a Freer's again. See, Weber is pressing on the orbit. Can you see that? Weber?
Yes, yes, sir. Very nice, sir. Stankiewicz sign, sir.
Yeah, this is called the Stankiewicz sign, right?
Yes,
Pressing
sir.
the orbit and you're seeing the movement. So that is one thing you must understand, that damaging the orbital plate is not a problem. Don't get frightened. But once you damage the orbital periosteum, your periosteum will come out and then you could have a little bit of fat, your fat prolapsing into the field and cause you trouble during surgery. Okay. Now again,
Yes, sir.
here I will explain if fat prolapses, what you're supposed to be doing. Is that clear?
Yes, sir.
So now we have all our limits of dissection. We have here a nice maxilla. I've shown you frontal. I've shown you supraorbital recess. I've shown you the anterior ethmoidal artery. I've shown you all the posterior cells dissected. And here you have the sphenoid sinus opening over here. Right.
Yes, sir.
Now, do you want to go into frontal sinus or sphenoid sinus? What do you want to go into? Or you want, okay, let me show you the maxilla. Let me show you the extensions of all this procedure. This was a basic phase. Okay, one thing which I wanted to tell you all is, there is a question which I remember some senior people also talking about it on various forums. I won't name the person, very senior persons. They said, if you have a polyp not involving the frontal sinus, I will not touch the frontal sinus. Okay?
Yes. What is your opinion, sir, about it?
Exactly. I'm coming to that. Polyps arise from the ethmoidal sinus, and generally the polyps involve or the polyps prolapse into maxillas, or give me a 0-degree endoscope, please. Prolapse into the maxilla or into the frontal, right? Now, you know that you want to do a complete ethmoidectomy from front to back for polyp surgery, right? Hitesh bhai?
Yes, sir. Yes, sir.
Right? You want to do a complete, give me a curve suction. You want to do a complete clearance of ethmoidal cells front to back. What
Yes,
are
sir.
pneumatizing into the frontal?
Ethmoid.
ethmoid cells.
Yes, yes, sir.
If you
So we
don't
have to remove the cells up to the recess.
exactly, if you don't open up the frontal recess, how the hell can you say you're doing a complete ethmoidectomy?
Yes, yes, sir. True, sir.
You can't say that. So you're defeating the real purpose of the cell's definition itself.
Yes,
So
sir. We should remove the cells, but sir, we should not touch the ostium.
yes,
If disease is not there.
exactly. So you
Yes.
have to clear the frontal ostia. Then only
Yes, yes, sir.
all the ethmoidal cells. Two, what is the idea? Is it a surgical disease or it's a medical disease? Polyps. It's a
Medical, sir.
so if I don't open up the frontal recess, if I don't clear it up, okay, my mucosa is going to become still thicker and thicker and thicker because it's a medical disease.
Yes, sir.
Operatively, I require a wide maxilla, I require a wide frontal, I require a complete exentration of cells so that when I irrigate this nose post-operatively, it not only breathes well, irrigation will help to clear off the mucin. The accumulated mucin or the inflammatory mediators cause a localized reaction in various areas like this maxillary sinus. If I don't irrigate, there'll be a localized mucin here. It will cause an edema of this mucosa.
Yes, sir.
If my medicine doesn't reach here, a localized edema of this can cause a very cobblestone appearance looking of this mucosa. My spray
Yes, sir.
just come and hit here. Here, no use. My sprays are not going here, not going here. What's the use? Right?
Yes, 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 sir.
Use sprays. The idea is to ask the patient to spray effectively so that it goes into all the areas. Now, my personal opinion is in the post-operative period, after clearing of all the cells, I ask these patients to take high volume irrigations with Budicort. Okay.
Yes, sir. Same here, sir. Yes, sir.
What that does is it washes away. Now, after surgery, there'll be blood and blood clots everywhere, right? So you
Yes, sir.
drill amount of irrigation. A nasal spray like Sol spray will not really reach everywhere and irrigate the area.
Yes, sir. And it also not reach by forcefully, sir. Also.
Not back into the sphenoid. So you want high volume irrigations like Jalniti, which clear off all the clots, which clear out the mucin, which clear out the inflammatory mediators all through and cause this mucosa to settle down. Now,
Yes, sir.
I believe the future is also going to be all of these techniques where you're going to get companies giving you ready-made high volume irrigations with steroids in it. Okay. So many of us give long-term sprays. Sprays do not reach every nook and corner, right? So the future has to be irrigations. And that is why you want to have a clearance of the frontal, you want to have a clearance of the maxilla, you want to have a clearance of the sphenoid. Even if you have limited polyps sitting over here, not enough just to do an ethmoid and say, ho gaya kaam. No, because you want your maxilla to be open, frontal and sphenoid also to be open. So any case of polyposis, nasal polyposis, you have to do a full house fess.
Yes, sir.
No doing partial opening of sinuses. That's not acceptable to anyone. Okay, it's
Yes.
a disease. It's a part of a process which requires, and that's why you have recurrences. Clear?
Yes, sir. Clear, very clear.
You want to add anything to that?
No, sir. I am doing same, sir.
Okay.
Except frontal. If no disease in frontal, then not touch the frontal ostium.
Yeah. So, okay. So I was having an argument with a very senior person, and I said, "How the hell do you say you finish your surgery without going into the frontal?" Okay.
Yes, sir.
So
Yes.
reason is because we have a lot of ethmoidal cells over there.
Yes, sir. Yes, sir. Frontal recess itself is ethmoid, sir.
Correct. Exactly. Okay. So here I'm looking into the sphenoid sinus here. Okay. This is still a small party wall between the sphenoid and the posterior ethmoids, which is a little hard bone. We'll take that out later. Don't worry. Let us show
Yes,
the.
sir.
Now you asked me if I want to widen this sphenoid.
Yes, sir. So is the sir nasoseptal branch.
Yeah. Give me a sickle knife quickly. Anything. Sickle knife. Blade. 50 number blade at the 50 number blade. Anything. Sickle knife de do now. Give it. So I already described this to you. Now
Yes, sir.
further on what I'm doing. So once I showed you how the vertical olfactory
Yes, sir.
fibers are here, and these are all the horizontal fibers.
Horizontal. Yes, sir.
Here I will start from the lateral most end of the the sphenoid sinus. Come here, okay, with my cautery. We use cautery for this. We come here and then we incise this at the junction between the vertical and the horizontal fibers. Can you see that? It's
Yes, yes, sir.
same plane. Can you see this middle turbinate?
Yes, sir.
At the same level as that of the middle turbinate. I don't have to come down here. I can stay here and
Yes, sir.
all the way up to the
Anterior face of the middle turbinate.
This is the genu or the turn of the turbinate. I can come right up to here. Can you see this?
Yes, sir.
Incision liberally all the way coming up to here. Now this is an incision for what we call the rescue flap. Okay.
Yes, sir. Yes,
Rescue
sir.
flap means I'm only preserving this pedicle, and if necessary, if I get a CSF leak, I will harvest that pedicle. Correct?
Yes, sir.
That is what is rescue flap. I will talk to you again about that.
Okay, sir.
So here I'm just trying to finish my incision. Okay, it's a little
Yes.
difficult to do this with a sickle knife. So we use either a blade or we use a cautery. Anyway, done. Don't worry.
Yes, sir.
So give me a Freer's elevator. So what I'm doing is I'm taking this flap a little bit downward. Can you see what's being exposed straight away?
Yes, sir.
So this is the rostrum of the sphenoid. Can you see that?
Yes, yes, sir.
Here you see. So this is how we preserve the pedicle. Can you see this here?
Yes, sir. Yes, sir.
All this down. Okay. Take all this down here. And here you'll see small sort of
Is it-
grooves
is
over
Palatovaginal canal, sir?
palatovaginal here. Can you see this?
Yes, yes, sir.
So here you get palatovaginal. You have to bipolarize it, sometimes oozes. But this is how you sort of release all of this. See, I removed that. Okay.
Yes, yes, sir.
Yeah, I'm going far laterally and I'm taking off this flap from the bone, right?
Yes, sir. Yes, sir. It contains pharyngeal now.
Now, you usually over here, you see this, we take an incision down here. So if I'm doing a pituitary surgery, I'm supposed to take an incision and take this down. But I've stopped doing this, Hitesh, by taking the lower incision. Nishit insists on taking the lower incision, like you saw in his surgery last week. I
Yes,
don't
sir.
take the lower incision at all. I just take this like this. That gives me enough exposure to remove this bone.
Okay, sir.
Require it, I just put this back. I don't even take the lower incision.
Okay, sir. Okay, sir. Yes, sir.
Helps a lot in mobilization. But there are two different schools of thought always. We all
Yes, yes, sir.
He's a fantastic surgeon, as you saw last 2 weeks.
Yes, sir. He has done very nice pituitary, sir.
But here I don't take the lower incision. I differ in that. Don't take a lower incision, okay?
Okay, sir.
Give wipe the outside. There's a mucus on the nose, the tip of the nose. 1 minute. Bata? This hair is coming in the way. इसका कोई बात नहीं हो गया निकल गया. So this is the front face of the sphere. So this, what you call, is nothing but the rescue flap. Can you see?
Yes, sir.
For all the juniors, this is called the rescue flap. You would do this on both sides, okay? Both sides, that side as well as this side. Now from here, all these things here I told you are the olfactory fibers. Suppose I had to harvest a Haddard flap. Give me a sickle. I'll show you the marking. I won't harvest it, but I'll show you the marking for the Haddard flap again.
Okay, sir.
Here, okay, I can swing my incision going superiorly over here. Okay, swing here. I'll come back out, clean the scope and go back in here. Okay. So here I come, I swing my incision superiorly as I come to the anterior face of the middle turbinate, swing
Yes, sir.
with the cautery up here. Now here, I don't go right up to the crib, I leave a little space there. Can you see that's all
Okay.
fibers back? I'll
Yes, sir. Yes, sir.
go right up to there, but I'll stop somewhere here and then come forward onto this area.
Yes, sir.
Forward onto this area as high on the septum as possible and come to the junction, mucocutaneous junction over here. Correct?
Yes, yes, sir.
I already described has to be, we take it like this, we come
Yes, sir.
along the floor of the, or come along the junction between the septal base and the floor or maxillary.
Yes, sir.
Come like this all the way anteriorly and then sort of join the superior and inferior incisions. So that forms the Haddard flap. Okay?
Yes, sir.
Haddard, when do we use Haddard? We use it for a lot of pituitary or stellar lesions. We use it for transplanar lesions. Okay, when we do transplanar surgery, we use
Yes, sir.
it's a little overkill to use Haddard flap for small CSF leaks. All right, you already
Yes,
saw
yes.
surgery done at Morbi where he used a middle turbinate flap,
Yes, very nice, sir.
smaller flap there, which he used for CSF. But CSF leaks, by and large, you can do small CSF leaks even without flap. You can just put fat and fascia, but
Yeah.
do that. Okay, so we have to have bare bone. The principle is you cannot have mucosa wherever you have CSF leak. You have
Yes, yes, sir.
bare bone, create bare bone on both sides for about at least 1 centimeter on both sides of the defect, and then put your fat there, it will accept. If you don't create bare bone, this leak is most likely to fail. or repair is
Yes.
pain. Okay, that's the principle. And again,
Yes. Yes.
keep the fat tight against the skull base, right? On that,
Yes.
what you put is secondary. On that, whether you put fascia is secondary, on whatever. So your primary layer is all that is most important. Clear, everyone?
Yes. Yes.
Okay. So coming back to maxillary approaches, now let us show you the region of the and nasolacrimal duct first, because that juniors are inside. So when you do a nasolacrimal duct surgery, you would, this is the axilla of the turbinate, you would
Yes, sir.
go to 8 millimeters ahead of that, come about 8 millimeters anteriorly, come downwards over here. Okay, now I don't have a very sharp blade. Give me a blade.
Okay, sir.
Give me a blade. 15 number blade. Okay. So I'm using a 15 number blade. Now, when we start incisions, ideally we always start from below. We'll ask why below? Because
Yes.
bleeding then comes down. If I start from the top, blood starts
Yes. Yes, sir.
lower incision goes. So I'll make my incision first over here, right over here. Okay. Can you see this incision over here?
Yes. Yes, sir.
Then I go superiorly over here. I've made this incision already. I'll stick to the same incision. Come out 8 millimeters anteriorly and take this incision over here.
Yes, sir.
So this is all going to be a flap which I'm basing posteriorly. Give me a Freer's elevator. Can I have the table little up because I'm having to bend? So once you do that, you start elevating this the mucoperiosteal flap here. Because when I'm looking higher up now, I'm having to bend too much down. Straight visualization is okay. So whenever we are taking the table up because this is a, sorry, that's enough. That's enough. Thank you. Because this is a cadaveric specimen. Patient's head can be turned here and there, but this cannot be, okay? So here you're seeing I'm elevating this flap. Now, as you do this, you tend to have some amount of oozing because mucosa or mucoperiosteum is very, very, vascular. So you get oozing. So what we do is use adrenaline soaked gel foam or adrenaline soaked patties and then keep putting it in this region and sort of elevating this. Where do you elevate it? You elevate it right up to the edge of the bone. Can you see this edge of bone coming up here?
Yes, sir. Yes, sir.
That's the edge of the bone. Can you see my instrument going there?
Yes, sir. Yes, sir.
The bone that you need to identify and expose. Okay. So now give me a
Yes, sir.
scissor again. The lower incision is not good. Just cutting this lower incision better. If there are any questions from the junior audience, we have a lot of distinguished faculties in the audience. Please ask questions. Give me this thing, scissor. Please ask questions. They will answer it.
Here is extra mic is here. If anyone wants to ask the question.
So this dissection is not for Hitesh Bhai or Yash Pandya, okay? It is for all of y'all. Hitesh Bhai already knows what I'm doing. Okay?
Yes, yes, sir.
Yeah, so it is meant for all you people whom Dr. Sejal has called me for. Right?
Yes, sir.
Sure. So this bone is exposed. Now, what bone is this? This is nothing but the frontal process of maxilla. All right?
Yes, sir.
I have
Yes, sir.
thin bone, which is the lacrimal bone, just about there. Can you see this? The lacrimal bone. Right?
Yes, sir.
Bone easily cracks up. No big deal. Give me a back punch. So now what I'm doing is I'm showing you what I have to do for a DCR. I take my punch here, go into this groove, go behind this bone, and sort of punch this. Can you see
Sir,
this?
sir, sometimes we couldn't pass the punch in the shallow groove. Then what to do? How to start the surgery?
If you cannot pass a punch, take a chisel hammer and hit this bone a little bit. Gentle fractures on the bone, and then you remove it. Okay?
Okay, sir. Or we can drill that area also.
Drill is very elegant. Best. Okay, Weber was asking you between drill and punch. Drill is always most controlled. Punch
Yes, sir.
punch takes a little more time. Drill is very elegant. You have anything, chisel, hammer, kuch bhi hai. Give, chalega, chalo. Don't worry. So I'll show you how to do it with backward biting. With drill, it is the most elegant thing. When you do a backward biting, you see what I'm doing? I'm taking my instrument in the area there. I'm not trying to grab onto a tissue behind it, right? Behind the bone. Give me, huh? Chale, kuch bhi de do bone. By the time you remove one. So I'm taking this, putting my instrument there, and then biting. I require a very stout punch. This is not hard enough. एक और बात between these two, just keep removing the bone dust and giving me. Yes. इसको ऐसा थोड़ा कर सकते हैं? Yes. That's so this is the way I would want juniors to do it. Okay, even if it takes
Yes, sir.
minutes, use a punch or use a drill. Don't use chisel hammer. Okay.
Yes, yes, sir.
Tempted because Vaibhav told me there's a chisel hammer here. I'm taking this trouble only for you guys. I can do it easily with the chisel hammer. But
Okay, sir.
we want to teach. कोई बात नहीं, चलो. Anyway, give me a chisel. Let me get this faster out. I'm doing this as a chisel only for the sake of demonstration, but don't use chisel hammer. Give me chisel. चलो hit. पतला वाला नहीं है. एक मिनट. पतला वाला देना. एकदम रूलर जैसा. हाँ. Akshada, why did you take that? You want to hammer my hand? Huh? You snatched it from Mitram. Hit. I can see that khunnas in your eyes. Hit. 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 Give me the bigger chisel. Mitram, take over. Chalo. Give me the chisel. Give me a little stronger one. Not this. The other one which you gave me. Straighter one. Chalo, maro. I'll just crack it up a little bit. It saves us time. Nothing more than that. Okay? Weber hit. I mean, Mitram hit. I hit. 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 Stop. Hit. 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 Not working as expected. So, Nikant, give me this thing. Punch again. The chisel is not very sharp. So sometimes you have thick bone and many people you have thinner bone. Okay, each person's bone
Yes, sir.
thickness. Idea is you have to just keep exposing that sac which lies just posterior to that. Okay, or lateral to that bone. Correct. Now the
Yes,
reason I'm
sir.
showing you this is one, it covers the anatomy of the sac, and then I can also show you maxillary procedures. All the maxillary procedures. See, Weber is pressing on the eyeball. Can you see that?
Yes, sir. We can see the movement of the sac.
So the bone in the lower part is easier to sometimes take out. The bone on the superior aspect, okay, I'll show you what we mean by superior
Yes,
aspect,
sir.
is sometimes thicker. Give me a
Yes,
40.
sir. Thicker, and also we have difficulty in angle also, sir,
Correct.
to remove the bone.
8%.
So sometimes require drill to remove that bone.
So here, I'm removing out all this bone over here in this step. In this. Good. There's a bone chip. It was a big bone chip. Which, give me a forceps. 8 forceps. So here we have removed a big bone chip, as you can see.
Yes, sir.
You can see the bone is quite thick.
Yes, sir.
Give me a punch again.
Sometimes we accidentally enter the agar cell there.
Yes. The agar lies just on the posterior edge of this area.
Bone. Yes, yes, sir.
So this area, as you go superiorly, is thicker bone compared to below. Give me a ballpoint probe. So this area, you'll be able to punch out bone much more easily than this area. This
Yes, sir. True, sir.
very thick bone, and chisel hammer is not a good idea because you can hit and go into the orbit. You can go into this ethmoidal cells. You can cause sort of any amount of damage. Okay, so not a good
Yes, sir.
chisel hammer. So drill is a better idea. If you think this bone is too thick, you have to drill this bone to expose the the nasolacrimal duct in its there.
So what is the superior limit of sac exposure, sir?
Yeah, so you should ideally be able to go above of course I'll show you. Give me a ballpoint probe. You saw the mucosal incision. Mucosal incision went above the turbinate, right?
Yes, sir.
Now I'll expose this superiorly so that I can see the upper limit of this. Now, when you open this, you should ideally be able to see the this thing, common canaliculus.
Common canaliculus. Yes, sir.
So if you're just going to incise this area, it's going to fail. You need to go higher up there and identify
Yes, sir.
the common canaliculus.
Directly marsupialize the common canaliculus inside the nose
Yes,
to
absolutely.
prevent recurrence.
Absolutely. Anyway, the reason I wanted to show you this is because I can show you the maxillary procedures. You asked me about pre-lacrimal approach. So I will
Yes,
show
sir.
everything related to the maxilla with this procedure being done. So this serves the purpose of teaching the juniors, like I told you, endolymphatic, endonasal DCR, and also will teach you what is the pre-lacrimal approach as I go into the maxilla. I'll show
Okay,
you
sir.
the procedures there. Okay.
Hello. Sir, sorry to interrupt.
Yes, go on.
We have senior faculties from all over Gujarat, respected members of ESR. We have our neurosurgeon with us. So we have a full house audience, sir, witnessing the dissection.
Oh, that's nice. Thank you. And
And one more international faculty from Germany, Dr. Mohammed, with us in the audience, sir.
all right. Welcome, Mohammed, and welcome to all the senior faculty and neurosurgical colleagues, senior neurosurgeons, I believe. Thank you very much for being around. Okay. So as I go a little bit into the sphenoid, I think that's where all the neurosurgical work will come in. But I'll also show you posterior wall of maxilla, which also we sometimes require neurosurgeons to be around because all the approaches to the skull base are also seen along the pterygopalatine and infratemporal fossa areas. Correct?
Yes, sir.
So here I'm just going to stop doing this nasolacrimal duct exposure. Okay, as long as you'll have got an idea, give me a ballpoint probe. I'm not going to incise the endolymphatic. I mean, again I say endolymphatic, nasolacrimal duct. Okay, press on it. Can you see that quite effectively? Okay, this is
Yes, sir.
the mucosa. Now this mucosa I'm going to trim off for the time being. All right. At the end
Yes,
of
sir.
nasolacrimal, I mean DCR surgery, we make a horizontal incision over here and try to cover the bare areas. Okay, cover this superior aspect. This lower part goes towards the posterior wall. But now, right now, I'm going to just take this off. Give me a debrider or give me a scissor, whatever you have. Okay, every junior is clear about this.
Yes, sir.
sir.
Yes, sir.
Okay. So we create flaps on this. This I'm just debriding for the sake of further demonstrations.
Okay, sir.
Suction on this is blocked. On this suction is blocked. Give me a scissor. So if I have to do a end of this flap, okay, this flap is taken down here. Let me just show you what we do. By the time the debride clock, we take this thing, we cut this flap horizontally over here,
Okay, sir.
horizontal incision like this. Just clear that the suction is blocked over. Okay, give me a ballpoint probe. This superior part over here, the superior aspect of this pedicle flap goes like this onto the bone to cover the upper aspect.
Okay, sir.
If I cut this, give me a scissor. If I cut this a little bit more here, and now it's better. I cut this like this. So you see, you don't want to leave raw areas for a good surgery. So
Yes, sir. Yes, sir. Sir, what I do from the beginning, I do double flap technique
yeah, correct.
from
And
the beginning only.
so this is exactly what Dr. Hitesh Bhai is talking about. And I trim this and I keep this in opposition to the posterior margin of the sac. Once I open this nasolacrimal duct, I remove this and oppose this to this like this. So the healing
Yes.
is very fast, and then there is absolutely no issue of the flaps closing back or the sac closing back. Yeah, I just take out this flap for the time being. My idea was to show all maxillary sinus techniques. Okay,
Okay, sir.
this out. I wanted to keep the nasolacrimal duct there because then it tells you how the pre-lacrimal approaches work, how the
Yes, sir. Yes, sir.
okay, good. So now you have the lymphatic. I mean, again, I keep saying nasolacrimal duct. What is happening to me today?
Sir, in DCR, where to put the incision over sac for the benefit of juniors?
Okay. Give
In
me
the middle part, anteriorly, posteriorly, where exactly? We
Sure.
have to divide the sac.
not going to incise. I've got a blade, but I'm not going to incise it. You have to understand that this, I go a little bit more on the posterior aspect, not exactly in the midline, little bit beyond 50% on that side, because this opens like a book. When I opens like a book, I want this to cover the anterior part of this bone. Okay.
Yes, sir. Yes, sir.
Posterior part is very close to the mucosa over there. So posterior part, I can just oppose it easily to the mucosa. So I keep
Okay,
a
sir.
posterior flap and a little larger anterior flap.
Okay, sir.
Okay, coming down to maxilla, right? We had
Yes,
already
sir.
what is normal maxilla, what is the how do you widen the maxilla to its maximal extent. Okay. Now here, what I want to show you is what we do at Denkers. Okay, I already showed you inferior maxillary, maxillary
Yeah.
angle, right?
Yes, sir.
Now, give me a blade. Drill भी है ना? Webber, इधर ऐसा पकड़ इसको. So here you see this is the pyriform aperture.
Yes, sir.
This here, you see that?
Yes, sir.
Not that. I'll hold. I want you to hold this instrument later. So this is the anterior most end of the middle turbinate. This is the
Inferior turbinate.
pyriform aperture. I'm pressing on this. Can you see that?
Yes, yes, sir. First palpate the interior border, sir, right?
पकड़ दबा के रख. Give me a blade. So here, what I'm doing now is I'm taking an incision on the pyriform aperture. Usually we do this with a cautery. Okay.
Yes, sir.
Taking an
Cautery or coblator, sir. Yes, sir.
oblator, cautery, whatever. We are identifying
Yes, sir.
pyriform aperture over here.
Sir, is there any significant blood supply there, sir? Sometimes
Yeah, you can have some vessels, but you have to use a
uh,
bipolar
branch of the facial artery, sir.
patients. Yeah.
I forgot the name.
Yes. Yeah, you get many branches from facial. So
Yes, sir.
above is correctly doing it. You have to separate this a little bit from the anterolateral wall. Can you see this periosteum?
Yes, sir. Yes, sir.
From the anterolateral wall of the maxilla over here. Okay.
Yes, yes, sir. What is the sir lateral limit of separation?
See here, now we are not doing what we call it Denkers. Okay, we are doing only a medial
Okay.
maxillectomy. Denkers ke liye you'll go right towards the end of the posterolateral wall and expose the infraorbital nerve.
Yes, up to the infraorbital now opening.
Further back, I will keep going towards the infraorbital nerve. Okay, I don't want to go all that way back. See that? That's your
Yes, sir.
orbital wall. Correct? Now in
Yes, sir.
surgeries, I don't want to go there. I will just elevate a little bit. You can see this is the medial wall of the maxilla. This is the
Yes, sir.
wall of the maxilla. Okay, give me a blade. Okay, and keep the drill ready, or give me a chisel hammer if you have, whatever you want. So usually what I do is I take a drill, I go into this area over here. Okay. Okay. Good. इसको हटा के रख. And who's going to give me a suction, or someone has to hold a scope? Anyone. So what I'm doing is this burr is a little large. इससे छोटा burr है? इससे छोटा burr दे दे. चलेगा दे दे चलेगा. I'll tell people it's okay. It's okay. Forget. Don't, let's not waste time. So usually I would use a little bit smaller burr and drill into this area. The idea of is just to gain entry into the maxilla. Clear? Now, hello?
Yes, sir.
The idea is just to gain an entry into the maxilla. Okay?
Yes, sir.
Now, this burr is a little bit larger than I would like, but it's okay. Wash. Keep a suction there. Yeah. Yeah, suck, suck. You have a lovely Medtronic burr over here. It's a coarse diamond. It's a beautiful burr. It's doing its job wonderfully. Give me a suction. Give me a wash here, please. So people wonder what I'm doing here. I'm just showing you clearly. I use a little smaller burr, but this is going to give me entry into the maxilla in a minute. Okay?
Yes, sir.
Bone of this individual is really thick. Otherwise, by now,
Yes,
it's inside the maxilla.
yes. Sir. We can use a hammer and chisel also, sir.
I've gone into the maxilla already. I'm just widening it. I'll show you what I've done. Suck, suck, suck. Suction is blocked. Put a straight suction if you want. have already entered into the maxilla.
Yes, sir. We can see, sir.
Modified Denkers. This is not Denkers, modified Denkers. Okay. So nowadays we don't do Denkers. This is just an entry into the maxilla. Can you see the maxilla?
Yes, sir. Very clear, sir.
Give me the burr again. So what I want to do in certain procedures is enter the maxilla in this way. Now, what procedures would entail me going here? Is the next question, right? And you asked me about free lacrimal approach, so I'll just describe that to you. Just let me drill a little bit more here.
Okay, sir.
One minute. Give me a suction. वैभव उसको laterally पकड़ के रख इसको. Wash. Wash. Start. Thank you. Okay, can you see this area now?
Yes, sir.
Okay, good. So a little bit on the base still needs to be done. I will show you what is pre-lacrimal approach now. Okay. And what
Okay, sir.
is maxillectomy. Now, suppose we have a lesion like an inverted papilloma, which is attached to the medial wall of the maxilla. Okay.
Yes, sir.
Medial wall of the maxilla means this area here. This one.
Yes.
Right.
Yes, yes, sir.
Or if I go into the nasal cavity, this area. Give me, chhod de, chhod de. Give me a straight suction. So I want to take out this medial wall of the maxilla, correct? Can you see this on both sides? Clean the.
Yes, sir.
So we have inverted papillomas, which appear like polyps on the front, but which are true inverted papillomas, right? Which are attached to the medial wall of the maxilla. So what you really want to do is remove this
Medial wall. Inferior turbinate.
inverted papilloma also, as well as the medial wall. Can you see that? This is the,
Yes, sir.
the maxilla, and this I've entered the maxilla from here. So what I need to remove is this wall in the middle of this with the middle turbinate, correct?
Yes, sir.
The camera is okay. क्या हो गया? क्या हो गया? Clean the tip. Drill burr point नहीं लगना चाहिए, नहीं तो 0 degree खराब हो जाएगा. हाँ? बता. ए? Yeah. Clarity is not there. Burr तो नहीं लगा ना इधर? Clarity नहीं है. It's just give another 0. Okay, we can see that the 0 degree there is giving us sort of a double vision. Anyway, simply put, now you can see the nasolacrimal duct, correct? Give me a
Yes, sir.
So pre-lacrimal approach is when you want to remove this wall or enter the maxilla anterior or pre this lacrimal duct, nasolacrimal duct area, correct?
Yes, sir.
What I'm doing is, I'm sorry, the vision is not excellent. They're giving me another 0 degree scope. Hit with the chisel hammer. 1 minute. Hit. Hit. Hitting my hand. Mitra. Hit. Hit. No. Hit. Wait. Hit now. Hit. 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 Slipping. You have a broader one. Bada wala do. Only one hit is generally enough. Hit. 1 minute. Hit hard. That's it. Done. Only one hit I got told you. Now can you see this? This bone has come out here. And what I'm doing is I can separate this from the nasolacrimal duct. Can you see that?
Yes, sir. Yes, sir.
The nasolacrimal duct. So the whole medial wall of the maxilla can come out preserving the nasolacrimal duct. Correct?
Yes, sir.
Prelacrimal may you enter the maxilla anterior to this nasolacrimal duct area. Can you see that?
Yes, sir.
Yeah, I'm coming to that, how to cut NLD. Now here there is still a little bit of bone which I'll drill. Give me a burr. Let me finish this part of the drilling.
Okay, sir.
Wait, don't flush. Don't do anything. Don't do anything. One minute. I hope the burr has not touched the scope. Stuck, kabhi stuck. Not clear. Give me wash. Okay, give me a forceps. So when I have to remove the medial wall of the maxilla, this is exactly what I will do. I will take out this entire block of bone, and now I have only my nasolacrimal duct in my way. Can you see that?
Yes, sir. Now, how to manage the duct, sir?
Yeah, I'm just talking to you about how to manage the duct next. I was hoping to give you another 0-degree scope, but I hope the picture is not bad.
We can see, sir.
So here you have to go right up to the floor, okay? Now when
Yes, sir.
this nasolacrimal duct, give me a Freer's elevator or something. This is the whole nasolacrimal duct. The reason I did a DCR was to show you the anatomy of the the nasolacrimal duct from top to bottom. All right.
Yes, sir.
Now, once you remove this, there is wall behind this duct. Can you see this? So I
Yes,
can
sir.
take out this wall. This wall is pretty easy to take out. Scope. I'm just changing the scope. Now this is also the same. कैमरा में क्या होगा? न्यू बट ठीक है, पर उधर भी एज डबल आ रहा है ना? Edge should not be double. See this, the edge is coming. Where's the stores guy? तो ये edge double क्यों आ रहा है इधर? इसके clarity नहीं आ रहा है. No, it's give me the other 0-degree. 1 minute, let me see. Okay, we'll switch to the older one. At least you could see something. ठीक है. Camera में कोई setting change नहीं किया ना? See the periphery? Periphery is coming. Okay, anyway, as long as we can see. कोई बात नहीं, चलो let's go ahead. अब करो. Is it focused? Hitesh bhai, is it focused there for y'all?
Yes, sir. Okay, sir.
1 minute, he's got another camera, this thing. 1 minute. We'll just try with another one. There is no problem with the scope. It was probably the cam. This is cleaner. ये पहला क्यों नहीं दिया इन लोग? Okay, we have a clearer picture now, right? Yeah, this camera is better. There's a problem with the camera. You're getting a recording?
Yes, sir.
Okay. So now here, you know, this is the orbital wall, right? Floor. Orbital floor. Can you see that?
Yes, sir. Yes, sir.
Now here, when you have this NLDs over here, you want to prevent accidental damage to the NLD, right?
Yes, sir.
Get damaged. Okay, give me a forceps. If it does get damaged, then you should identify it and cut it cleanly, or then you should stent it. Okay.
Okay, sir.
Suppose I want to deliberately cut this. Now, like I'm doing a medial maxillectomy, I want to prevent, I want to deal with it and prevent it from stenosing in the future.
Yes, sir.
Then
But it's sharp and oblique, sir.
exactly. I'll do it right at the floor of the orbit.
Yeah,
Now,
junction of the floor. Yes, sir.
Yeah.
Border of the floor.
if I cut the nasolacrimal duct here, if I cut it here, sorry, the scope was not clear. In the tip of the scope. If I cut the duct here, the duct is going to fibrose. Okay? Nasolacrimal duct. So whenever we want to deal with this, what we do is identify it right up to its entry. or exit from this orbital flow. Can you see that? Bone.
Yes, sir. Yes, sir.
It exactly and sharply over there. So one single cut over here in this way, you do it, and then that remains good, right? So it does not stenose because it is nothing, it's within bone, right? And then
Yes, sir.
it is down. Give me a ballpoint probe. So here you'll see this will be the duct, and we have this open and it's flush with the floor, right? The bone over here actually will be whole. I've taken this bone out over here just to show you the anatomy, but bone over here is going to be intact in medial maxillectomy. So the bone is going to be all around this duct and it doesn't cicatrize because all within the bony canal. And this will be the duct. Now press on the this thing. So you'll see little fluid coming out of there, okay?
Yes, sir.
Normal
Yes,
individual
sir.
fluid coming out. So that's how you deal with the duct, nasolacrimal duct. You cut it right at the orbital floor, flush with the bone, so that it doesn't cicatrize, right? And then this exposes your whole medial wall. Yeah, yes, scope. Clean the scope. So this is all your medial wall, which is clean now. Okay, clean means free for removal. Is that clear, everyone? So now I'm going to take a scissor. Give me a scissor. I'm just going to cut off this, the turbinate as well as that is the part of the turbinate and the nasolacrimal duct. I'm cutting this to show you all the further anatomy, right? Give me forceps. Hitesh bhai, is that clear to everyone?
Yes, sir.
Anything different that anyone does? Give me this thing, scissor. So here at the posterior part, I'm just cutting this turbinate, okay?
Hi, this is Dr. Muhammad Badi
Hi.
from Northern Germany. I enjoy your demonstration for the next time. 2 weeks ago was fantastic, and I'm enjoying it also right now. I've
Oh.
got a question which I'm struggling with back home in Germany. Empty nose syndrome after turbinectomy. Do you have an experience with that? Would you have kind of treatment, management, whatever you could advise me with? Because at least I've got like 10 patients who is I'm struggling with. And that, these people mostly were like operated in Turkey, where they have been the turbinectomy done inferiorly on both sides. Do you have any advice for me how I could manage such a complication?
First and foremost, I've seen a lot of people doing unnecessarily turbinectomy. Okay.
Yes.
For routine surgeries, if you have a turbinate hypertrophy, I'm against doing any procedure on the turbinate. A turbinate is a structure which is basically physiologically, it increases as as per the physiology. So it can increase during the nasal cycle, it can increase due to allergies, it can increase in size due to infections. Just because you see a hypertrophy turbinate on a scan doesn't mean you have to run after the hypertrophy turbinate. Clear? So first and foremost, no inferior turbinate. You may do a septoplasty, you may do an endoscopic sinus surgery, you may do anything. Don't touch the turbinate. The turbinate can be removed. If it's removed unnecessarily, then you get crusting because you're destroying
Yes, definitely.
surface. You get crusting, you get bleeding if you're not, because it's richly supplied in the healing period, you can get bleeding. But more importantly, during the later course, you could get a little bit of crusting. You could get a little bit of anosmia depending upon which turbinate is removed. And you could also get a lot of dry nose syndrome because there is no mucus in your nose. Okay, you have destroyed the complete mucosa of the inferior turbinate. So you get a dry nose syndrome. But by and large, you should not touch. Give me a debrider 1 minute. By and large, you should not touch the inferior turbinate, right?
Yes.
On the other hand, if you have a surgery like a medial maxillectomy, okay?
Yes, but back home, I've got 10 patients who come regularly to me for examination control and whatever. I'm asking you whether you have kind of experience or management advice for me, because they are coming regularly with crusting, with
You have to give them nasal spray, washes. irrigation, you can do nothing. That's why I told you it's mainly prevention. Once you get that empty nose syndrome, there's really nothing much that you can do. Okay. There are techniques described where you can, inject certain materials or even sort of put, certain allografts, etc. Nothing works in short. All right. Empty nose
Yes.
syndrome, nothing works. You just have to irrigate the nose. Is it clear?
Yes, sir. Sir, request to show us middle and inferior turbinoplasty on the opposite side, if it is possible.
See, okay, turbinoplasty is something I don't prefer.
Okay, sir.
I can show you, I can demonstrate to you, which is the only thing which is acceptable. But by and large, we don't do turbinoplasty as well. All right.
Okay, sir.
But if you really want to only remove the bone, I'm okay with that. Don't touch the mucosa. Bone just reduces the dimension of the inferior turbinate, which also sometimes or many a times is not necessary. It's clear?
Okay, sir.
Okay. So coming back to this medial maxillectomy part, I showed you what is prelacrimal approach. I showed you what is how do you remove the medial maxilla. Suppose I have an inverted papilloma attached to this medial wall over here. I need to take out this whole medial wall right up to this floor. Is this clear, everyone? I need to remove this entire bone right up to the floor and make this flush with the floor of the maxilla. So if I drill a little bit more over here, I can make this flush. Is this clear?
Yes, sir.
So here you see, I'll just do it in a minute. Just take it down to the floor. Just keep a suction there, please. I'll just show them for demonstration purposes. Okay. So ideally, you require a good combination of suction irrigation. I'm doing fast. So we are just using a suction. Irrigate, please now.
Sir, do you recommend any surgery about atrophic rhinitis?
No. No surgeries for atrophic rhinitis.
What is management of atrophic rhinitis,
Again,
particularly in children?
nasal washes, your solutions of, you can give antioxidants, vitamins, you can give washes regularly. Okay. But
Okay, sir.
really nothing else. Okay. Now coming back to this, give me a Freer's elevator. So you have seen what is a medial maxillectomy, correct? Correct?
Yes, sir.
Full medial wall of maxilla gone. Right?
Yes, sir.
What is prelacrimal as an approach, prelacrimal, and I showed you what is medial maxillectomy in cases of inverted papillomas, in case of carcinomas arising from the medial wall of the maxilla, or as an access to also your angiofibromas. Angiofibromas
Yes, sir.
access to the posterior wall of maxilla.
Yes, sir.
Right? So here I showed you what comes as an access to the posterior wall of maxilla as well. Right? Is that clear to everyone?
Yes, sir.
Yes, sir.
Let's go further on this. Now here, what you can see, I told you, is the perpendicular plate of the palatine bone, right? So here,
Yes.
I'll just strip out this mucosa a little bit over here. I'll strip out this mucosa so you can see everything else.
Sir, will you show us the maxillary artery and how to ligate it?
Everything. I'll show you everything. You want to see till the nose is empty, I'll show you that. Not empty nose syndrome, but I'll show you till the nose is empty. There's
Okay.
so I'm just trying to go sequentially. There's too much I can show on this, okay? I can show you full endoscopic skull base, infratemporal fossa, transtubercular, transplanum, sphenoid, procedures on sphenoid, procedures on maxilla, procedures on frontal. We have lots to show, but we may not have all that time. So let's just do what we can do right now. I'll show you that. I'll definitely show you that. That's exactly where I'm headed now.
Yes, sir.
So here you see, this is your perpendicular plate of palatine bone, right? So here I'm just clearing off the mucoperiosteum. There's a piece of mucoperiosteum attached here. So you have to go deeper to the periosteum. Just focus it better over there. No, focus. छोड़ दे ठीक है. I'm going to focus on this. Give me your debrider again. So please don't do this with a debrider. This is not exactly I'm just showing this for demonstration. What you need to do is you need to go to this perpendicular plate of palatine bone, okay, and keep shifting the mucoperiosteum laterally. Can you see this? As you go laterally over here, you start seeing this bone. Okay, this bone is nothing but the perpendicular plate of the palatine bone, and it has got two processes. One ahead here is nothing but the sphenoidal process, and the one going back there is nothing but the orbital process. Between the sphenoidal process and the orbital process, you have this artery coming out here. Can you see this? This notch. Can you all appreciate this?
Yes, very clearly, sir.
So this is nothing but the sphenopalatine, right? Coming out
Yes.
of the sphenopalatine foramen. Give me a suction, please. So you have to follow this perpendicular plate and go to the notch which lies exactly between your sphenoidal and the orbital process. Give me a straight forceps. Now, sphenopalatine artery, I'll just show you in again the complete anatomy as you wanted. Give me a forceps. Sorry, not a forceps, frias. Frias. So here you see, I'm going here showing you the sphenopalatine artery. Can you see that? So when
Yes,
you
Yes,
sir.
sir. Yes.
see it, now the sphenopalatine artery branches, multiple branches there, right? Really, when you want to ligate it for a posterior epistaxis, you don't just ligate it here. You need to expose it a little bit more. Give me a punch. So what we do is we take a punch, go into this area over here and sort of try and remove this. Can you see that there? Expose more of it. So here, again, you see, I'm going in here and sort of breaking it. Sorry, support the head. Can you see this coming out now?
Yes, sir.
Give me a Freer's elevator. Let me remove all this top stuff. Above, okay, everything is seen well. Jeet. Forceps again. Give me that punch again. So here you see, I have to go into this groove, put my instrument there and keep punching. Can you see that?
Yes, sir.
Yes, sir.
Once you do that, you come more and more towards the main trunk. Give me a Freer's again. So when you pull this, you should see a good length of your sphenopalatine, right? See that?
Yes, sir. Yes, sir.
Good length of your sphenopalatine, and then you can clip it. Okay. This is
Yes,
for
sir.
sphenopalatine artery ligation. So you have to go towards a little bit here. Make sure you're not seeing branches only. You're identifying the main trunk. Now this sphenopalatine, I told you, it gives out supply to the inferior turbinate over here, right? So the branch to the inferior turbinate doesn't come right at the posterior most end. It comes somewhere down here at the junction between the posterior 2/3 and the anterior 2/3 and the posterior 1/3. It enters somewhere over here. Again, you will see branch from this going there. You can see it going towards the turbinate. Can you see this?
Yes, sir. Yes, sir.
Going
Yes,
towards
sir.
the middle turbinate here. Multiple, 2 or 3 branches going here towards the middle.
Yes.
So here, this supplies the middle turbinate, and then you have the branches that supply the
Septum.
septum over here. That's the posterior nasal branches of the sphenopalatine, and that's all the basis for the hard flap. Is
Yes,
that
sir.
clear?
Yes, sir.
Sir, can you show the posterior septal branch?
We can't show it. It's multiple branches. All these are branches.
Okay.
Yes, sir. Yes, sir.
See this? It's not a single branch. It's multiple, like an arcade. Can you see all this?
Yes, yes, sir.
All multiple branches. So you can't identify it like a sphenopalatine. It's all small, multiple branches over there. So it goes there into the septum over there. Similarly, okay. Now,
Yes, sir.
to the posterior wall of the maxilla, we have talked to you about what is medial maxillectomy. Now, you also want to find out what you do for case of. Okay. Now, one more point I wanted to point out:
Angiofibroma.
angiofibromas and other stuff. Be a ballpoint.
Yes, sir.
Can you see this over here? This is what the inferior orbital artery, inferior infraorbital nerve here runs
Yes, sir.
and forms a sort of a projection on the infraorbital wall here. Can you see that?
Division of the V2.
Yes, V2. So now give me a punch. Let me see. So ideally, what we do is we take this punch, go like this, and keep taking out the wall of the maxilla. Okay.
Yes, sir.
So this is going to take time if I do this. So again, to expedite things, what I'll do is give me a chisel hammer. No, chisel hammer. This is only to expedite. Okay. This is not what we do in surgery. This is a very soft bone. Okay.
Yes, sir.
There, you saw that?
Yes, sir. Yes, sir.
A very soft bone. It. You don't even need to do this. Hits have to be very gentle. Okay.
Yes, sir.
Okay. Stop. Give me a suction. Give me this thing. What do you say? Punch again. So go into this, create some cracks, go into this area, and then take out the entire bone. Went in. Okay. Take this. In it. So the minute we take out this posterior wall of maxilla, what we are seeing is fat. Can you see that?
Fat. Yes, yes, 3 layers, sir.
Yeah, there it's
One is fat,
yeah.
second is vessels, and third is nerve.
Correct. Absolutely correct. In. Oh, they've given us an absolutely fresh specimen. I can see blood coming out from the periphery.
Yes, sir. Thanks to Sejalben and team, sir.
Yes, madam. So I must thank Dr. Sejal for putting up this program, doing all the arrangements. Complete credit to her and her team there.
Sir, almost the hall is full.
Acha, okay. That's nice to hear. Give me a suction. So this wall is generally eggshell thin, okay? Support the head.
Yes, sir.
So punches are not strong. Okay. Support the head, sister. I'll just have to remove the entire bone of the posterior wall to show you all the anatomy of the nasopharynx, pterygopalatine fossa, infratemporal fossa, and all
Yes, sir.
then both. Okay, and then we'll go on to sphenoid and show you all the transsphenoidal approaches. We want to discuss anything else till then, anything that we have probably missed out in trying to show so much. Okay, we have discussed ligations, we have discussed sphenopalatine, we have discussed maxilla, all the procedures possible, and we have also discussed frontal sinus.
Can you show us the greater palatine branch of?
I'll show you that. Give me a chisel hammer. I'm just going to expedite it by using a chisel hammer, okay?
Okay, sir.
It. It. Hey, बहुत ज्यादा नाश्ता किया. Little slow. Okay. Give me a punch. As I told you here, I have 4 fantastic assistants. Jeet and Vaibhav, I think you all know. Okay.
Yes, sir.
And here I also have with me Mitram, who's from Surat. I think you all know him.
Yes, sir. We all know.
Rising young star. He's a very keen guy. Okay, let's hope he's also able to take up to all this. And we have Akshada over here, who's also come to Morbi, and she's from Vashi. Okay.
Yes, sir. All for done excellent help in our workshop, sir.
Yes.
To all. Yeah.
Yes. So all they make me look good, and it's credit to them. Okay.
Yes, sir.
So Vaibhav and Jeet also used to travel with me throughout the country and meet everyone. Give me forceps, straight forceps. Meet everyone and try to assist me for every possible way. So they're reliving their time with me.
Yes, sir. Both are obedient.
Yes. Not only obedient, sweet guys, to be honest.
Yes, sir.
Very enthusiastic. I mean, really.
Yes, sir. Both had got first prize in junior consultant award in last AOI, sir.
Correct.
It's proud moment for you and also proud moment for PDU also, sir.
Yes, absolutely. We're all proud of all of y'all. This bone is getting a little thicker as it goes down here. I'm just trying to take out so I can show you the entire anatomy at one go. Just have to bear with me for 1 minute more, that's all. Give me chisel hammer. Hit. 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 Should I hit? Hit, yeah. Hey, don't worry. Hit, yeah. Hit. Hit hard. Really hard bone. Mitram mar. Tu hi mar. Hit. 1 minute. Hit. Hit. That's right. 2 shots from Mitram and it's done. Shada, you require 10 shots. Hit. Hit. Stop. Hit once more. Hit. Hit. Hit.
So we can use drill and make it.
Yeah, we can do that. So just trying to save some time.
Yes, sir. Yes, sir. Yes, sir.
So I wanted, see, it's very easy. I always tell Satish shows bone removal so fast that juniors think it is very easy to do all that. Okay.
Yes, sir.
We use the instruments that we are supposed to use in surgery. If you have to use punch, I'll tell you have to use punch.
Yes, sir.
You have to use drill, I'll tell you we have to use drill. So everything is not just pulling out with this thing. Fuse elevator. You have to be gentle. Dissection is an art. Okay. It's very
Yes, sir. True, sir.
out everything, but at the same time, you want to show people how it's to be done, right?
Yes, sir.
Give me again punch or give me a punch. Just remove a little bit more here and we're done. Yeah, I'll just remove this bone so everything becomes clear. Okay, give me. So I did not punch. I just used it like a leverage and I pulled it out. Okay.
Yes, sir. Yes.
People, you have to learn all these techniques of how to remove big chunks of bone without damaging any of the underlying structures. Okay.
Yes, sir.
You see, even the fat will not get damaged. Even if you use a chisel hammer, fat,
Yes.
yeah, nothing, vessels, nothing. Okay, now we'll go down to the anatomy of this region. Okay, although this thing is out. Okay. So what we are seeing now, give me a free earth. What we are seeing now is a maxillectomy having been done. We have taken off the posterior wall of maxilla. Let me take out this also. What is this? Okay, give me a scissor. Let me just take that out for the time being. That's okay. Ready. So the areas are divided into. Give me. Sorry. Just give me 1 second to take out this piece. Yeah. Doesn't matter. Give me a Freer's elevator or a ballpoint probe, whatever you have. Okay. So medially here you have your nasopharynx, correct? We all know this is nasopharynx.
Yes, sir.
You have the pterygoid plates, the medial pterygoid plate and the lateral pterygoid plate, and here you will have the pterygoid wedge.
Wedge. Yes, sir.
So this medial pterygoid plate for all the juniors is nothing but the lateral wall of the nasopharynx.
Yes, sir. Yes, sir.
So this lateral wall here is nothing but it is formed by the medial pterygoid plate.
Yes, sir.
Medial pterygoid plate,
Yes, sir.
correct? Give me a forceps. So as you go onto the top or base of the medial pterygoid plate, on the top what you're seeing is nothing but the pterygoid wedge.
Yes, sir.
So this is the pterygoid wedge here. This is the medial pterygoid plate. I'm just palpating this for you. Okay, palpating, and that's going to be the area of the lateral pterygoid plate. Correct?
Yes, sir.
Nasopharynx lies medial to the medial pterygoid plate. Pterygopalatine fossa lies between the medial pterygoid plate and the lateral pterygoid plate. And
Yes, sir.
infratemporal fossa is everything lateral to your lateral pterygoid plate. All this is infratemporal fossa.
Yes, sir.
Second thing, second relationship. This is the pterygoid wedge. All right.
Yes, sir.
Happens to be the base of the sphenoid. Can you see this here?
Yes, sir.
This is the base of the sphenoid. Can you all see that? There's a
Yes, sir. Yes, sir.
What can you see? I'll show you some two structures over there. I'll go on to that. But more importantly, coming back to this area, clean the step.
Median canal
Yes,
and foramen rotundum.
perfect. Okay. So here, if I keep shifting this down here, you'll see two canals. One here. Can you see this here?
Yes, sir. Yes, sir.
This is Vidian. Yes, that's the one. Vidian.
Yes, sir.
And just
Funnel shape.
you'll have the foramen rotundum. Okay.
Yes, sir.
Yeah. Can you see this here? This is mucosa. Okay, wait, this is not. I'll just clean this off. Give me a suction. Mucosa. Need to remove this mucosa anyway. Okay, chalo, koi baat nahi. Give me a free elevator. So you know that the pterygoid wedge has two openings, right? One is the Vidian and two will be the
Foramen rotundum.
rotundum, right? So I already
Yes.
told you the Vidian is here. Just lateral to that here will be your foramen rotundum. Okay. Now numeration of the area here, which goes like this between your Vidian and your foramen rotundum is going to be nothing but the lateral recess, right?
Yes, sir. Yes, sir.
So when you want to deal with lateral recess leaks, what you need to do is a trans-pterygoid approach. So
Yes,
you
sir.
take your instrument and go into the lateral recess from up there. You need to drill this pterygoid wedge and go with a 0-degree endoscope to this area of the lateral recess. Is this clear, everyone?
Yes, yes, sir.
So this is exactly what I wanted to show you there. You can see this opening here. This is nothing but the V2. Can you see this here? Yeah.
Yes, sir. Yes, sir.
Okay, quite clear there. It's coming like
Yes, sir.
column becoming the infraorbital nerve. Can you see this here?
Yes, yes, sir.
Okay. So
Yes, sir.
Median there, and I showed you this thing. So the pneumatization between this is going to be nothing but the lateral recess. Is that clear?
Yes, sir.
Okay. Juniors, are you all understanding this anatomy? This is a very important anatomy. Okay. The angiofibromas generally arise from the pterygoid wedge over here. Okay. And they go here behind the wall of the maxilla. So generally you will see they increase the space between this pterygoid and the maxilla, which is called the pterygomaxillary fissure. Correct?
Yes, sir.
Pterygomaxillary fissure. So widening of the pterygomaxillary fissure on CT scan is pathognomic or almost conclusive of angiofibroma.
Fibroma. Yes, sir.
Yes, sir.
So when you want to do an angiofibroma surgery, you have to see this pterygoid wedge area. You have to see sometimes it's attached down there to the nasopharynx. It goes like this, it flops, falls into the sphenoid sinus. It's never attached into the sphenoid sinus. Okay. It goes like this,
Yes, sir.
orbital fissure towards your middle cranial fossa. Okay. It can go past your superior orbital fissure into the cavernous sinus,
Yes, sir.
come down into the infratemporal fossa. So all the extensions for angiofibroma. Is it clear?
Yes, sir. Yes, sir.
Two, as soon as you take out the posterior wall of maxilla, you can see here it is all fat. Can you see this?
Yes, sir.
If I tease out the fat over here, Okay, sometimes we can use debrides, but I don't want to do that. I'm going to show you exactly what we do in live surgery. There's not too much fat. What you can see is blood vessels coming in there. Okay, as
Yes, sir.
by Dr. Hitesh, it is
Yes, sir.
and there is always blood vessels over here. So you need
Yes,
to
sir.
identify. I already showed you how your sphenopalatine artery is running, right?
Yes, yes, sir.
From here, this is the sphenopalatine artery. Can you see this here? This sphenopalatine artery, can you see it here?
Yes.
Yes, yes, sir.
It is an extension of your internal maxillary artery. So what
Yes,
I
sir.
do is I need to identify all the vessels. I'll just tease all these tissues in this way and try to show you the main internal maxillary vessel. Okay. Now, internal maxillary artery is a branch of external carotid, right?
Yes.
It starts laterally, way laterally. Akshada, you're listening. Itram. That's way laterally and gives out three segments. One segment is far lateral, one is middle, and one is medial.
Yes, sir.
Sphenopalatine is the most medial branch. It also gives out branches like the middle meningeal going superiorly. It gives us greater palatine and lesser palatine coming down here to going towards the palate. Okay, and various muscular branches it gives out in its middle and lateral parts. Is this clear to everyone?
Yes, yes,
Yes.
sir.
Yep. Keep it ready. I just asked for it. So here there'll be multiple branches from the internal maxillary. I'm just trying to tease it open. And internal maxillary is always going to be looping around. Okay, it's going to be a very loose loop around. You have to tease out all this fat. You can see the blood vessel over here. You can see this blood vessel. All of this is all the loop of the internal maxillary. Okay, I just have to remove all this fat and show you more and more of the internal maxillary. Give me that ballpoint probe.
Is this posterior alveolar branch?
Yes, this one, yes. Here it's going down. It is
Yes, yes, sir.
alveolar branches here, palatine branches there, and
Yes, sir.
the loop, big loop of the internal maxillary. Okay.
Yes, yes, sir.
I'm forgetting the name of the muscle which was dividing it into three parts. Yeah, pterygoid, lateral pterygoid. Right, right. The lateral pterygoid muscle is just over here, right? So
Yes, sir.
the first division here. There you go. Okay, you can see the trunk. Yeah, yeah. So you can see a multiple loopings of vessel, but this is all mainly the internal maxillary. So when you're doing an angiofibroma surgery, you need to identify this main vessel here, okay, lateral to the tumor, right?
Yes, yes, sir.
Find the tumor and then go and branch it. Sometimes you take off the main internal maxillary. Sometimes it may have various branches over here, which you can additionally ligate. Okay. So here you see it's a little tight. I'm not able to do it properly with this, but you can make out that this is the loop, right? You see that loop there? Loop.
Yes, yes, sir.
Cut it if at all. Give me some instrument. So Weber was asking here, when you do when you do angiofibromas, do you embolize? Okay. I would always embolize. I know Satish will not embolize because Satish identifies the maxillary artery, okay, internal maxillary artery entering the tumor, ligates it there, and that is what he calls intraoperative embolization, right?
Yes, sir.
Prefer to embolize. It's just two differences. Though we can all identify the internal maxillary artery, I would prefer to embolize it. There you see. Can you see that? Yeah, that's the muscle there. Okay. This is the muscle. This is all the lateral pterygoid process. Can you see this? The lateral.
Yes, sir.
This divides the internal maxillary into lateral branches and medial branches, right? So this is all coming from here. You have to find out the loops. There it is here. Can you see this here?
Yes, sir.
This is the main internal maxillary artery. I have to expose more of this bone. I'll make the camera straight. Can you now see this? This is the main internal maxillary.
Yes, sir.
I'll put an instrument over there. This is the main loop of the internal maxillary. That's it. Can you see that? It's not going out to the other side. Let me see. Yeah, see this. Yeah. So this you can isolate. You can come out. The angle of the instrument is not coming out. नहीं, कोई बात नहीं, आ गया almost. Just going and touching up, butting against something else. Okay. Anyway, can you make this out?
Yes, yes, sir.
Went there. So this is the main loop of the internal maxillary. Can you see this?
Yes, yes, sir.
Yes, sir.
This internal maxillary comes out over here, and there you can see it continuing as the sphenopalatine over there, right? Some
Yes.
branch going down here. Can you see this branches going down here? This is nothing
Yes, sir.
but palatine. Can you see this vessel here?
Yes, sir. Greater palatine.
Right? And here, as you had said, this is inferior alveolar branches over here.
Yes, sir. Yes, sir.
Okay, all of these branches going down here. So
Yes, sir.
a little bit more exposure over here. Now, behind this vascular plane, what you see over here is nothing but the lateral pterygoid plate or the pterygoid wedge itself, right?
Yes, sir. Yes, sir.
Give me a Freer's elevator. This is the pterygoid wedge, and you have to go to the lateral pterygoid plate here. You can see that there's an edge there. I'll probably have to remove a little bit more bone over here to show you the V3.
Yes, sir. Yes, sir. Mandibular foramen, sir. Sir,
Mandibular-
after embolization, you also ligate the artery during surgery?
Yes, I would additionally ligate the artery during surgery.
Okay, sir.
So this is all going to be
At which level you ligate, sir?
here, lateral to the tumor.
Lateral to the tumor. Okay.
It's the tumor medially, I go to the lateral end and then take it over there.
Okay, sir.
Okay. Now, here you can see this is all the greater wing of the sphenoid bone, correct?
Yes, sir.
So over this, okay, over this is all your middle cranial fossa. Correct?
Yes, sir. Yes, sir. Yes, sir.
So this infratemporal fossa, because this is all middle cranial fossa. Is it clear to everyone?
Yes, yes, sir.
Fossa here, if I go laterally here, the middle cranial fossa has the Gasserian ganglion, and from the Gasserian ganglion, it gives out V1, which goes towards the cavernous sinus, V2, which continues down as the infraorbital nerve, okay, and V3, which goes down past this mandibular foramen coming down to the mandible, correct? The infraorbital nerve continues forward along the floor of the orbit, okay, along the floor of the orbit, and continues forward and comes out as the infraorbital nerve on the cheek,
Yes, sir.
right? Is this clear to everyone?
Yes, yes, sir. Very much.
Okay. So now come back to sphenoid. Since we have the neurosurgical colleague, we'll come back to sphenoid. We'll show them all structures.
Sir, can you remove the tissue and show us clearly the foramen rotundum and median canal?
Okay. Freer's elevator though. I'll have to take off the middle turbinate if you want, but here I'll show you this. See this. Can you see over here? This is the foramen rotundum. Can you see this?
Okay, sir.
Right? It's going down here. See, I'll show you this. It's going completely here. Can you see this nerve coming out?
Yes, yes, sir. Yes, sir.
If I take it down, it's going exactly to the floor there. Can you see that?
Yes, yes, sir. Yes, sir.
This is your V2, foramen rotundum, right?
Okay. Where is the median canal?
Median is here. 1 minute. Suction de mere ko. In the tip. See that there. Just here.
Okay, sir. Okay.
Okay, down here. It's just probably it's been a little snapped, but it's here, just here to my suction. Can you see
Okay,
that?
sir. Okay, sir. And medial to it is, I think, palatovaginal also.
Palatovaginal we already showed, but just lateral
Yes,
to
yes, sir.
median, and above that is your rotundum. Can you see that?
Yes, yes, sir. Yes, sir.
Or on the base. And here is where we had the palatovaginal.
Yes, yes, sir.
At this groove where we broke it, right?
Yes, yes, sir.
Good. So what's the time? Okay, lot of time. Good. So are you all enjoying the dissection, or is it just
No, 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 sir. Enjoying. All are enjoying, sir. All is full almost, sir.
okay? Good. Maxillary strut. This one is asking Whoever was asking what line,
Optic strut and maxillary strut. Please show us, sir.
yeah, I'll show you that. He's jumping the gun. मैं थोड़े टाइम के बाद दिखाता हूँ when I come on to
Yes,
that.
yes, sir. Yes, sir. Yes, sir.
Okay. Chalo. So let me go on to the sphenoid, which should interest you guys. Give me a Freer's elevator. Okay, so now here I have my turbinate here. Okay, middle turbinate. What I'm going to do for you is I'm going to deliberately cut this middle turbinate today. Okay,
Okay, sir.
give me a scissor. So when I'm cutting the middle turbinate ever in expanded endoscopic approaches, I have to cut it horizontally. I cannot go right up and cut it at the axilla. I'll cause a CSF leak. So I leave a
Yes, sir.
thumb, keep it here, and then cut it. Okay.
Yes, sir. Preserve the 5 to 7 millimeter, 5 to 10 millimeter
Yes. Cut it like this.
for anatomical purpose also.
Yes. Cut it like this, right up to its back end, and then shift it down. Can you see that? I shifted it
Yes.
down. And when you shift it down, it's pretty easy. Doesn't bleed. And there you have its posterior attachment to the, clean the tip of this. Posterior attachment there to the lateral nasal wall, right? I'm just cutting that as well, just for making the anatomy clear to all of y'all, okay? Because
Yes, sir. Yes, sir.
anatomy will on both sides of the turbinate, but I want you to see it at one single, in one single frame. Only for that reason, I'm taking off this turbinate, okay? This
So routinely, how you manage the middle turbinate, bogey middle turbinate?
bulky, if there is concabulosa, we sort of reduce it, okay? But if it's big, I don't need to do anything. I can just sort of lateralize it. If it's
Okay.
concabulosa, you definitely have to reduce it.
Okay, sir.
So there now you have a clearer view of your flap. Okay, you have the view of your sphenopalatine artery. Someone asked me about the posterior nasal septal artery. It goes in past here, okay, and supplies the flap from here. See this?
Yes, sir. Yes, sir.
Yes, sir.
So here I'm shifting this whole mucoperiosteum down. So you're preserving the mucoperiosteum because the blood vessels are multiple. Now can you make out? So this was the whole idea of taking off the turbinate. Can you see that? So once
Yes, yes, sir.
you're preserving your whole vascular supply on this side, correct?
Correct, sir.
Same way on the opposite side, I can preserve the, I can do the same rescue flap, but just to expedite things, I'm going from this side. I'm going to elevate this whole area and identify a sphenoid sinus from this side itself. Can you see this area here? Give me a
Yes, yes, sir. Opposite sphenoid.
go to a little bit. Okay, give me a scissor first. Let me cut this. I'm just cutting this mucopericardium on the opposite side. Okay, keeping it down here for the time being. Okay. All
Yes,
the olfactory mucosa, what we do is in surgery, 1 minute, huh? All this olfactory mucosa in surgery, we push it up. Can you see this?
Yes, yes, sir.
Push this up here on both sides. Correct? Preserve this
Yes.
olfactory mucosa and then remove the rostrum of the sphenoid. Correct?
Yes, yes, sir.
In pituitary surgery. Today,
Yes, sir.
clear the field for you. I'm going to debride this. Practically never do it. Okay? But just to show you some landmarks, I'm going to take this off. Suction is not working on this. Suction is blocked. So in all practical purposes, you have to just shift this up and you have enough space to do your job without having to,
Without compromise the olfactory mucosa.
olfaction.
Yes, sir.
Let me retain it. If I can show you the transcribiform, it will come off use. Okay. If I reach the transcribiform, it will come off use.
Okay, sir. Okay, sir.
So give me this. So right now what I'm doing is I'm just going onto the opposite sphenoid. I'm just creating a little bit more space over here. Save some time.
This is opposite the superior turbinate, sir.
Opposite superior turbinate. And I'm
Yes.
widening my sphenoid ostia superiorly. You'll notice I'm not going down. I'm widening it here.
Yes, yes, sir.
I'm sticking to the anterior wall of the sphenoid and taking
Yes, sir.
it superiorly. Now, how superiorly can you take it? You can take it till the roof.
Yes, sir.
Can you see this here? You can start
Yes.
seeing. them.
Yes, yes, sir.
Okay.
Can you show us the posterior ethmoidal artery if visible, sir?
Yeah. Okay. So Webber tells this is the typical owl's eye appearance. Okay.
Yes, yes.
Well, owl's eye, I'll just show it again to you. Let me clear a little bit of this mucosa. Give me this thing. Free of the elevator. So if you have seen an owl, these two are the owl's eyes, and this is the beak of the owl. Can you see that?
Yes, yes, sir.
Owl's eye appearance. Akshata, owl's eye appearance. See this. With Vitram. Okay, that's the eyes of the owl, and this is the beak of the owl. So this is the classic
Yes, yes, sir.
owl's eye appearance. Okay. Now give me a chisel hammer to expedite this again. So again, this now you have the sphenoid on one side, you have the sphenoid on the other side. But to gain access to the floor of the sphenoid, I don't have enough access. So what do I have coming in my way? This big bone, right? This is the front face of the rostrum of the sphenoid. So I have to take it out. Now here you have the vomer. Can you see this here?
Yes, yes, sir.
The vomer here. Okay. Perpendicular plate of ethmoid, vomer, and rostrum of sphenoid. So what I'll do is I'll take with chisel hammer just to expedite things. Give me a hit here. Give me a broad chisel if you have. Hit. This bone is not very thick, so it can easily get hit. Okay, hit. So this is called shoulder osteotomy.
Yes, yes, sir. Shoulder osteotomy.
Hit. It's not happening. It's not doesn't take. है कुछ बड़ा? नहीं रे. 2 मिनट में ही निकल जाएगा. भूनपन से 10 मिनट लगेगा. Hit. So here again, if you see, I will hit all along a certain direction in a controlled way. Okay, this is not
Yes, yes, sir.
controlled hits. This is all controlled hits. Hit. Sorry, hit. 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 Don't worry. Hit. अरे बिंदास कुछ नहीं होगा मेरे हाथ. Hit. Hit. On hit. Good. So you see what I've done? I've created a shoulder osteotomy.
Yes, yes, sir. Very nice, sir.
All coming till here. Similarly, a shoulder osteotomy can be done on the opposite side. Okay. And then we can take out this whole chunk of bone. Let me take this first here. This is still holding it back. Hit. Hit. Stop. Hit. 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 Hit hard. Hit hard. Okay, छोड़ दे. Now here again, I'm taking one cut here. Usually you use a drill for this, okay? I'll tell you why. Because this, you don't want it fracturing higher up. Okay, let me use a drill and show them. Give me a drill. So you want to show an elegant way of doing things, you want people to do wawa, you have to use a drill. Right? A more controlled way of doing things.
Yes, sir.
It's very fast with the drill. Can you see that?
Yes, yes, sir.
And you create only fractures where you want. You don't create unnecessary fractures. Same way here, one shoulder osteotomy with the drill itself. It's got stop. Pani dal diya. Give me a suction. Clean the tip. Give me the already loose, is it? It's already loose, so it will just come off. See that?
Yes, sir. Very nice, sir.
Give me a lux first. So this is a big chunk of bone which comes out as a whole there. Can you see that?
Yes, yes, sir.
All the junior people, are you understanding this? What is being done and why it's being done? If there are any questions, feel free to ask. This whole dissection is for you guys. Okay? Suction. The whole exercise we are conducting, the Rajkot ENT Association is doing is for all the junior people who are around so that they understand a lot of things about the anatomy and how to go about doing it. Give me a debrider.
Everyone is concentrating on screen only, sir.
Okay, let them ask questions. That's why. I mean, as long as they are clear, I don't mind them.
Yes,
not.
sir. We have a two mic here.
As long as they're clear why certain things are being done, I'm happy. If they're clear, they should not go home back with questions in their mind. That's
Yes, true, sir.
ये क्यों किया, that's the most important thing. करना है तो क्यों कर. और करना तो कैसे करना है. Those are the two main things that you are asked, and I think that's what we are trying to answer in this concept.
Yes, sir.
Yes, sir. But you are teaching in very simple way, sir. I think everyone can understand it.
Oh, good. Yeah, I'm trying to keep it simple without being
Yes, yes, sir.
complicated. We can show things in a very flashy way, but I don't want to do that. Okay. Simple.
Yes, yes, sir.
And sometimes it's good for them to see us doing things slowly or using different instruments, because it tells them we are all not God. You're seeing Satish, everything looks easy, right?
Yes, 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 sir.
Forceps, 45-degree forceps. So once we do this, we have an unbridled access into the sphenoid. Okay, you can already see. I mean, all the seniors already know what's coming up, but I'll just clear up some more tissue there and try to show you every structure the way it's supposed to be seen.
What is the, sir, ideal exposure of sphenoid in case of pituitary surgery?
Yeah, I'm coming to that exactly. Okay, give me a drill. Now, again, one thing is caution is here you can see a septation, right? You can see all
Yes,
the
sir.
septations. Don't try to break any septations in your surgery, right?
Yes,
You
sir. Sometimes septation may attach to the carotid or optic also.
don't flush.
Yes, yes. True, sir.
All these septations you would just want to drill out,
Yes, sir.
and that's what you want to teach them. You have to make this floor flush with the floor of the sphenoid. Can you see this?
Yes, yes, sir.
Floor is completely getting flushed, because later when you put a Hadad flap back, you will want to have this floor flush. And
Yes, yes, sir.
Hadad flap
Yes, sir.
to have a maximal exposure. The reason for failures in pituitary is because you've seen the cell and you're rushed into to remove your tumor. Okay. So
Yes, sir.
I'm asked what are the maximum limits for exposure. I'll just show you that in a second.
Okay, sir.
Wash lots. Give me a bigger section. Bada section है? It's a bada section there. A important part of your sorry, change to debrider. An important part of your surgery is to give a wide posterior septectomy. Okay.
Yes, sir.
So because when you start doing the cellar part, it's generally a four-handed technique where the neurosurgeon is also involved. Okay.
Yes, sir. Yes, sir. How much part of the septum should be removed, sir?
Yes. How much? It's a good posterior. There's nothing like how much adequate. I'll tell you what is a way to judge for junior people. This suction is not working. This suction is not working. Okay. So there's a question, how much of this septum should be removed?
Yes, sir.
The surgeon goes in from the opposite side. See this. I've kept my instrument is on this side. And my neurosurgeon is going from that side. Can you see this?
Yes, sir.
This, if it's hurting my scope all the time, I need to do a little bit more septectomy.
Okay.
Do my surgery like this. The flap is not coming in my way at all. If my scope is here, see this.
Yes, sir. Yes, sir.
But if I go back there, I'm not blinded. So posterior septectomy has to be done where a neurosurgeon is comfortable and this flap is not coming your way. If you're here and this flap is coming into your way, remove 2-3 millimeters of this flap still further on.
Okay, sir.
Okay.
Got it. Yes, sir.
So give me a bigger section. You have it. So Mitram, Akshada, are you seeing now all what I was trying to clean? Clean. Yeah. Yeah. I'll just clean up everything. इसको drill करेगा तो सब दिख जाएगा. Okay, let me strip the mucosa. Together. So now I'm doing like from both sides of the nose. Okay, what I'm doing, I'm stripping off this mucosa.
Yes, sir.
It's quite edematous right now, and because of this mucosa, you're not seeing your structures as effectively. Correct?
Yes, sir.
Septation over here. There's a little septation over here, and you can see certain prominences. Right? I'll just
Yes, sir.
all is seen, and I'll tell you what is the maximal extent of dissection. Okay, give. It's not holding it only.
Sir, blue color horizontal is intercavernous sinus?
Yes.
Superior and inferior.
Yes, absolutely. Absolutely. So an experienced eye can see things before the mucosa is removed, right? And that's
Yes, yes, sir.
it identified it earliest. Give me a debrider. It's not catching on to that this thing. So what we do is we take out the mucosa. I'm debriding it. Never do this in live practice. In live practice, strip it. Okay.
Yes, 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 sir. Yes,
The minute you start doing this stripping of the mucosa, you get some amount of bleeding. That's because the
yes,
mucosa is richly supplied with blood coming from the bone. Right?
yes, sir. Yes, sir.
It is like I told you, you have to put some small pieces of Nerosil over there and keep it there or keep patties there and the whole thing settles down. Okay. Give pressure, wait for 5 minutes and the whole thing will settle down.
Yes, sir. Yes, sir.
Now, give me a drill still. Come on, let's change to forehand technique. Vaibhav, aa jayega? Vaibhav, Jeet, koi bhi aa jao. Aa jao. Okay, now we are shifting to a forehand technique. Okay.
Okay, sir.
Till now we were doing what is called the two-hand technique. Now this is very important for everyone to understand. Vaibhav is holding the scope for me. He's standing above, on my same side, but higher than me. Okay, towards the head end, and I'm going in with. Do you have a longer handpiece? It's not going all the way in. Longer handpiece. लंबा handpiece दे पहुंच नहीं रहे उधर. हाँ करो लंबा handpiece दे दे. Give me a instrument तब तक. चल. Give me an instrument. Give me another ballpoint probe here. Give me that. What do you have? Ballpoint. Okay. So what can you see right now while they are getting me the drill? You can see this is the region of the sella. Can you all appreciate that?
Yes, sir. Yes, sir.
The region of the sella. You see over here, I've given an exposure where you can see the plain tuberculum here. This is the soup
Yes, sir.
where the sella is beginning to curve forwards. Can you see this coming forward?
Yes, sir.
Sella coming forward here. Mitram, watch. Sella coming forward is planum.
Yes, sir.
The junction between the sella and the planum is your tuberculum.
Tuberculum. Yes,
This
sir.
is the superior intercavernous sinus.
Yes, sir.
The sella itself is covering this whole fossa. The inferior most part over here will be your inferior intercavernous sinus.
Yes, sir.
So people also, neurosurgeons will call this anterior intercavernous sinus and they'll call here posterior intercavernous sinus. And on both sides, you have the medial cavernous sinuses, right? So what you need to identify is your bulges of carotid. Now, what can you see over here? You can see this whitish impression over here. Can you see this over here? Starting
Yes, sir.
here and coming till here. Can you see this? This is nothing but the optic nerve.
Yes, sir. Yes, sir. Opticocarotid recess.
What can you see this bulge here? This is bulge of the carotid.
Carotid. Yes, sir.
Can you see this bulge here? This
Yes, sir. Yes, sir.
is the bulge of the carotid. So here you have the optic and here you have your carotid. This is the C of the carotid. If I drill out all this carotid will come like a C over here and then go down as a paraclaval carotid.
Paraclaval. Yes, sir.
So the C is more towards us, goes back and then goes down as a paraclaval carotid.
Yes, sir.
Right? See, that's the optic nerve here. There's the carotid and you can see the carotid turning there and becoming the paraclaval carotid over here.
Yes, sir. Yes, sir.
So this junction between the optic and the carotid, this junction is called the medial opticocarotid recess.
Yes, sir. Yes, sir.
The essence of this is that here you have to remove the bone to gain a complete exposure of the sella. Correct? That's the only
Yes.
case of that. Here, this area.
Yes, sir.
The one laterally over here is a
Lateral carotid. Opticocarotid recess. Lateral OCR.
opposite side ka bata. This is going to come here, opposite side, lateral optic.
Yes, sir. Yes, sir.
The lateral opticocarotid recess on this side, for example, you can see it very nicely. But this is because there is a pneumatization of the optic strut. Okay?
Yes.
The pneumatized anterior clinoid process of the optic strut cause this separation between the optic and the carotid. Sometimes if it is non-pneumatized, your opticocarotid recess will not get a deep depression like this. Is it clear to everyone?
Yes, yes, sir.
Okay, so that is the things you see.
Can you show us the area of the foramen lacerum and relation to the Vidian canal, sir?
I show everything. I want to explain the anatomy. 1 second. Pakad it. Let me remove this little bit of mucosa which is traveling. Give me a debrider. क्या आया? Drill लगाया तो drill दे. I'm just shifting this mucosa a little bit higher because it's coming in the way. Ideally, we don't want to remove it. We're just putting it up. Okay, drill दे दे. Okay, pakad. So anytime you do a transcellular surgery, pakad, remember? Anytime you do a transcellular surgery, you need to take care of these septations. Okay?
Yes, sir. Yes, sir.
Give me a ballpoint probe. Never twist these septations. I'll show you which one. So this is now a binostril axis. Never twist this septation. This septation is going here to the optic or to
Yes, sir. Carotid.
this septation is going here to the carotid and also to,
Yes.
so never
Yes.
two. Maximal exposure should be, I should be able to take out all this bone, make
Yes, sir.
it flat so that if I require a hard flap, there is no bony projection over here. I can just put my hard flap smoothly on this and come up here. So I need to drill this part. I need
Yes, sir.
part and I need to drill all these septations for a good transsphenoidal exposure. So laterally, I need to go beyond my carotids, right? So I need
Yes,
to
sir.
below the sella, access the floor. I need to go to my lateral wall of the sphenoid, not just the carotid, not just the carotid. I need to go to my lateral wall of the sphenoid. Is that clear?
Yes, yes, sir.
So Weber, chal, foreign technique. Keep it straight, Weber. Chal. नहीं, I want to show this bone. हाँ. एक मिनट. Weber, क्या हो गया? थक गया हाथ? हाँ? थक गया तो जीत को करने दे.
Hello.
Yes, hello.
Good morning, sir.
Yeah,
There
good
is
morning.
one question from a neurosurgeon.
Yeah.
When the tumor is lateralizing on any one side and pushing the carotids on any of the side, what care should be taken prior to removing the sphenoid bone?
I'll show you that again. When it's pushing the carotid.
Yeah, when there is displacement of the carotid because of the tumor on one side, when
Yeah.
a tumor is unilateral, then the damage doesn't occur to the carotids or vessel. What precaution should be
Yeah,
taken prior to removing the bone? Yeah, in during the exposure of the tumor.
yeah. So doing this is a regular tumor exposure for every tumor. What
Yeah,
I
I agree. Yeah, I agree. But for newcomers or learners who are sitting over here, in
Yeah.
such cases, what precaution should be taken to avoid the complication of injury to the vessels?
Exactly. So again, I'm saying that you need to have a wide exposure beyond the carotid. So for you see, I can see the stella. It's very easy for me to go on right now and take out the tumor. Don't ever do that. Okay.
Yes, yes, sir.
So exposure for all tumors is here. As I go inside, I'll show you how the tumor pushes on the carotid.
Yes, sir. And even when there is supracellular extension of a tumor, what should be the exposure in a bony way?
Okay, that is a good question. I'll just answer that also in a second. I'm coming to that right away there. Suction is blocked. Just let me drill out the septation a little bit more and I come back to that same question which you asked. Okay?
Yes, sir.
A minute more. Never go inside. अंदर जा. Go inside, Weber. Okay, so now here you see it's a fairly okay exposure thus far. Give me a forceps. Great forceps. in this. Okay. So here, stay here, Weber. ऐसा रखा. Here now you can start seeing that I've taken off this septation here. I've taken out the septation here. That's the region of the lateral OC here. Okay.
Yes, sir.
So I've got a nice wide exposure. Maybe I could have flattened this out more for it to look very picturesque. This suffices. Okay. Now,
Okay, sir.
when we do tumors, okay, pituitary tumors, we generally expose only the sella. All right. But
Yes, sir.
large pituitary tumors or giant pituitary, go closer. Giant pituitary tumors, we take out the tuberculum as well. Even if there
Yes,
is
sir.
a cellular extension, we don't go into the planar approach. We just take out the tuberculum. What that does it gives us enough laxity for this whole cellar to come down. Is that okay?
Yes,
Yes,
sir.
sir.
So here now again go Deva. Jeet aaja. Wise leve dur. Go close. Good. So now we have forehand technique where Jeet is holding the endoscope for me. And here I'm using the suction and the drill. Can you see this?
Yes, sir. Yes, sir.
To be done very gently. Can you see me drilling?
Yes, sir.
Movements, nothing. All
Always with diamond burr.
always with coarse diamond.
Yes, sir.
पानी scope पे मत डाल अभी.
And make it thin like eggshell.
Eggshell. Now in pituitary tumors, many a time this bone is already eggshell thin. It's
Yes,
only
yes, sir.
and acromegaly where you'll have really thick bone, or sometimes in case of craniopharyngioma, you have very thick bone over the sella, and you would really want to drill this bone as effectively. Otherwise, ये फटाफट निकल जाता है. Okay.
Yes, sir.
Oiled leg का bone come out थोड़ा सा and all make it straight.
So what should be the lateral border of this while doing, what care should be taken and restrict ourselves laterality?
Yes. So here, if you see laterally, I already have my carotid in my view, right?
Yes, sir.
Bas. See what I do. I'm drilling here like this in a C-shaped manner. Can you see this?
Yes, sir.
Yes, yes, sir.
Here I'm drilling in a C-shaped manner like this, going past to the lateral border of the medial cavernous sinus. This, it's a C-shaped drilling. It's not a vertical drilling. It's not a horizontal drilling.
Yes, sir. Yes, sir.
Stroke by stroke.
Good point, sir.
Yeah. So this burr is not cutting as effectively, but it's okay. Wash. So Medtronic has got superb handpieces. They have given us this nasal burr. Nasal burrs are very good for nasal surgeries. I enjoy, although the nasal burrs are excellent, I really enjoy doing surgeries with their long pieces and regular. Okay, use good is this thing Medtronic long burrs.
In such cases, sir, what should be the angle of scopes that ideally should be used while doing for the beginners?
Angle of the
Scope, 0 degree, 30 degree. Yeah, what sort of for ideal dissection of the cellar for
Zero.
for a beginner?
0 degree scope always. No angle scope for juniors. Okay.
Yes, sir.
All even I'm using a 0 degree scope just yet. You see what I'm doing? Now,
Yes, sir. Yes, sir.
when we use a pinch, tell you what we do. Come here, Jeet. सीधा कर. सीधा कर. So you see, I'm side of my burr to bone out. Can you see that?
Yes, sir.
I'm using the side of my burr. Can you see it's taking out millimeter by millimeter?
Yes, sir.
Yeah. Same way as you come superiorly here, you have to follow the line of the superior intercavernous sinus here.
Yes, sir.
The advantage of the burr is that your coarse cutting burrs will never hurt the sinuses. Okay. People use, give me a punch 1 minute. Let me show them the disadvantage of using a, when you punch, okay, you use it over here and lift the bone. As you go to the periphery, suppose you want to lift this bone, go close. You want to lift this bone. Here you have the superior intercavernous blue here. Can you see this?
Yes, yes, sir.
Cavernous is a double fold of dura. I cannot introduce my scope between this and the bone here. The bone is very stuck to the this thing dura over here, correct?
Okay, sir.
Use my thing and punch like this, I'm going to catch on and there's going to be bleeding from here. Same thing laterally. As I go laterally here, My instrument will go like this, but I should not punch because my upper end of the punch can catch hold of the carotid which lies there. Can you see that?
Yes, yes, sir, yes, sir.
Here. If I want to do anything, I go in this region. lift-
Break. Only break,
Yeah, only just
not
take
punch.
and lift this bone. Can you see that?
Yes, yes, sir.
Lift the bone after it's become eggshell thin.
Yes, sir. We can use Cottle's elevator also.
Absolutely. So depending upon what instrument, you have to be careful, and you
Yes,
have to expose your cavernous. Okay. The four,
yes,
what they call, you have to expose. So if there's a little bit bone that needs to be drilled there, I have to drill a little bit more and then expose that area. Correct?
yes, sir.
So no rough handling of tissues. Always control, and you have to expose going almost up to the carotid. Now, people say, why should you go almost up to the carotids? Right? Small tumors, just make a small incision and come out. Why go and risk touching the carotid? That's the major fear for people of all types, that we don't want to go even close to the carotid. Right? So you're not going to hit the carotid as long as you're using a diamond burr. You're not going to hit the carotid. First, clean the scope clean kar. It'll look clearer. So you will not hit the carotid first thing. Two is, give me a Freer's elevator. Two is, it's all about maximum exposure for even removal of small tumors. All right. What
Yes.
here is going to be the medial cavernous blue. If there is oozing from there, take a piece of Surgisil, put it there, put a piece of patty, it all settles down. Okay. Our neuro colleagues have taught us how to handle all of these bleeds. So, having them in the team is a big advantage. Even as ENTs, you handle bleeds of sigmoid sinus doing a mastectomy. So you should learn how to go about dealing with all these bleeds.
Yes, sir. Yes, sir.
So never get scared of sinus bleeds. So neurosurgeons teach us patience. We ENT guys want to just go quickly and hope the bleeding stops in a second. It doesn't happen like that. You have to go a little slow. Okay?
Yes, sir. Yes, sir.
Go closer. तो turn कर रहा है ऐसा रख ऐसा रख okay. Who was it? One important. Clean कर, scope clean कर. Give me a ballpoint probe or a sickle knife, whatever you have. Give them a clear view at all times. Okay? Aisa, this is the view. So what can you see over here? You can see the optic nerve here, your optic nerve here. You can see the C of the carotid. Can you see this here?
Yes, sir. Yes, sir.
Here also you can just about see the carotid there, right? You want to see the blue of the inferior, laterally the cavernous sinuses. Can you make out this blue here?
Yes, sir.
Yes, sir.
Yeah. So you have to see this blue here, and similarly you can see this blue coming up here. Can you see this? You have to put
Yes, sir.
all blue. Okay. So here you have all the four blues exposed. This part of bone again could come out. This inferior part of bone, this one could come out. Same way you have to expose this right up to this curve. Can you see this curve?
Yes, sir.
This is the maximal exposure you would want in case of any cellular tumor, any size. I'm not even talking of big size tumors, any size. Now,
Okay.
I'll repeat, it is all about maximal exposure. It is not only about removal of tumor, it is maximal exposure so that if there is a complication, you can deal with it.
Yes, sir. Yes, sir.
Two, as you look inside, in the scope pe kuch hai. So, two is when you look inside the cella, okay, the tumor goes in all directions. Go inside. Once you expose the cella, you want to take an incision right from your superior intercavernous sinus to your inferior intercavernous sinus, right from this sinus to this. Now, if I get scared of carotid and sinuses laterally, I just make a small incision over here and I'm going to do my surgery from here. What happens to tumor from here to here? Right? That's a problem. And secondly, if I have a wide dural incision, my neurosurgeon cauterizes the dura so it retracts away. Then I can take my scope inside the cella, show him the diaphragm, show him the carotids on both sides. We can actually do a complete surgery under vision. Is that clear?
Yes, sir.
Yes, sir.
Into this cellar cavity, I need a wide opening of dura. To have a wide opening of dura, I must have a maximal bone exposure. Clear? To have a maximal wide exposure, I must have a complete basal work as I already showed you. I cannot leave behind anything. Right? So everything for an approach this small, it's all your work. And here you can see I can reach the floor. My two instruments must be able to touch the floor. Sometimes you have tumors coming right up till here. You must go to the floor. Similarly, large supracellular extensions, I may drill out a millimeter or two more of this if I want. So it gives me laxity to push this dura up and sort of take the tumor out from intracapsular. Is that clear to everyone?
Yes, sir.
Our neurosurgical colleagues, do they have any alternative views, or are they in agreement with this?
Yes, sir, we do the same thing, but we go from the center to the lateral part. Just when the tumors are pushing the vessels to be on the safer side, we start from the center and then gradually go towards the laterality or above or below.
No, that's correct. I'm talking of exposure point. Tumor
Yeah,
removal has to start from here. Now, what he's trying to say is, if you start removing tumors laterally, okay, your diaphragm may suddenly fall down, or even if you start removing from here, your diaphragm immediately comes down. It will obscure tumor removal. So, tumor removal always starts from inferiorly. Start
Yes.
from here, then shift the tumor along with the diaphragm superiorly, remove it from this gutter, remove it from this gutter, and last clear it from the diaphragm so that it falls down. You're not obscured. Your gutters are not obscured. That's what he's trying to say. Okay.
Actually, what we feel when tumor starts debulking, automatically it starts falling down on its own.
Yes.
So it becomes very easy for us to dissect the tumor without damaging the pituitaries.
Absolutely right. Okay. So again, for the juniors, what are the endoscopic skull-based procedures possible? Right. And again, from the neurosurgical perspective also, whatever is possible and what is the latest concepts in the world. Pituitary tumors by and large, clean the scope. Clean the scope. By and large, pituitary tumors here, okay, are almost always done endoscopically. I think most people around the world have given up doing any other procedure. We have still people who do it sublineally. We have people who do it, approaches, but by and large, using a microscope. Microscope has superseded everything because of the visualization. Okay? So you do an endoscopic tumor removal, you can actually magnify this view. You can go closer and closer and give the neurosurgical. So the amount of visualization you get, the way you can look towards the carotid diaphragm, the way you can take out the complete tumor under vision is unparalleled by any other method. Okay, so endoscopic has ruled out. Now, what else can we do? For you, this is a region of the clivus. This is the sella, the tuberculum. This is the planum. Now, someone asked me, where is the posterior ethmoids?
Yes, sir.
Okay, come forward. Jeet, bahar nikal. This is somewhere the region of the posterior ethmoids here. Okay.
It is the anterior limit of transplanar approach.
That's the anterior limit of the transplanar approach. Okay.
Yes, sir.
So here, if you see this, here, I can remove my planar bone all this way up to here, where I find the posterior ethmoid, somewhere down here. Okay. So all the cells go out and all the bone also comes out. Laterally in transplanar approach, transplanar approach, you would have optic nerves. Go on. Sure. Give me that sickle once again. Okay. So here, if you go to a transplanar approach, you would have this optic nerves here laterally and or I say posterior laterally. So you remove the bone anterior to this, correct?
Yes, yes.
How do you remove that? Let me just quickly show you, and then I'll show you all the intracranial structures one by one once all the bone is out. Right? So let's go in. Keith, क्या हो गया तेरे को आज? ऐसा दिखाओ बस. लग गया तुम लोग? Okay, wait. You're doing great. All of you are doing great. Don't worry. Okay. So you see what I'm doing? I'm drilling the planum. Correct?
Yes, sir.
All this planar bone I'll take out. I will only cut the dura last. Go closer. Go closer. So you see, I'm not starting down here. I'm going all on the planum over here. Correct? Hey, this bone should have taken off. This burr is a little bit slow. By now, the bone should have actually come out. It doesn't matter. We'll still take 2 minutes more. Do we have a better burr than this?
ये बर्थ से नहीं हुआ है अभी तक तो हो जाना चाहिए था. रुक 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 को आप. So this is a true forehand technique where I have the assistant surgeon sort of showing using the endoscope, giving me a clear field, okay, clearing the field for me with water and keeping a scope in one hand. And here I got my suction and I got the drill in my hand, right? So I am
Yes,
using suction and the drill. Drill is in my hand, suction is. So this gives me a clear visualization. My assistant has to know when to flush and how to give me a visualization. And he's giving you the vision that you're seeing. Okay.
yes, sir.
So you see over here, I'm not taking off the tuberculum bone right yet. Tuberculum is the last bone to be taken out. First, I'm removing all this planar bone, right?
Yes, sir.
जीत ऐसा पकड़. Okay, stay steady. सिकल ओके ठीक है चलो. अपने पास कर्व्ड कुछ नहीं है ना? Curate नहीं. नहीं चलेगा ठीक है जाने दे no problem. So ideally we use a little flatter instrument and sort of take out this bone. Can you see this bone coming out?
Too much glare is there, sir.
Glare. Okay. Web of Jeet. Glare आ रहा है it seems.
जी થોડો સ્કોપ નું ડાયરેક્શન થોડું નીચું રાખ ને તો ઉપર ગ્લેર નહીં આવે. નીચું કે ઉપર કરીને જોઈ લે.
We have a very clear picture over here.
No, sir. Here is too much glare.
अभी
जैसे अंदर जाता है ना सर स्कोप ऐसे ग्लेर आ जाता है. हाँ. Okay, okay.
Forceps. So this is bone over the planum gone. Can you see that? Along with that, bone over the tuberculum has also come out because I made it very thin. So this is tuberculum. This is all planum. Can you see that? Can you see that?
Yes, sir.
Yeah, good. So I will open this dura last. I know the neurosurgeons will be anxious over here to see what comes in there. But I'll tell you where each approach is useful and what we should do. Okay?
Yes, sir.
I just take out a little bit more bone. Give me a punch. Harrison's punch chalega. Go up here. Planar पे देखा. नहीं planar पे देखा. Here I'm just removing a little bit more bone. Now people will say, why? What is the use of this approach? Okay, I'll talk to you next about all the uses of the various approaches. By using punches, sometimes we make inadvertent holes in the dura. That should be avoided. Give me a forceps. Nice, no. अब तो दिख रहा है ना?
Sir, we have adjusted here. Now no glare. Very clear picture.
Now clear picture. हाँ, because
Yes, yes.
बहुत अच्छा picture आ रहा था. This was
Yes.
Focus 6. Either it is okay. Go up. A burr is loose. Burr is coming out. Burr निकाल. Take it again. Anyway, ठीक है. वो part is okay. That much is okay. So you see a lot of the planum is exposed. Okay.
Yes, sir.
Yes, sir.
Would expose a millimeter or two more laterally over here. Give me a Freer's elevator or anything. Punch.
चलेगा. Punch in it. Shri de. Go in. Go in. Okay. All this bone is gone. Show me the other side. In.
Sir, can you also explain for what kind of tumor extensions, what should be the exposure limitations?
Yes, exactly. I'm just coming to. That's why I was just telling you. I'll tell you just now the use of this, of these all these approaches. Well, Jeet, show me this area. Okay. Take this. So here the transcellular I already explained to you is primary reason for doing transcellular exposure is pituitary tumors, right? The
Yes, sir.
tubercular approach here that you can see is give me a second. Give me a second. Transtubercular exposure is basically for doing surgeries like craniopharyngioma or tuberculum cellae meningiomas or planar meningiomas. Okay.
Yes, sir.
However, the ruling has changed the world. Earlier, because this is the tuberculum, this is the planum, and the meningiomas are facing us, we used to consider this endoscopic approach as one of the gold boons. Like you can actually bipolarize the tumor from laterally and take out the meningioma. Meningiomas, you cannot go head on. You have to go and decrease its vascularity laterally, gain a complete exposure, and then remove the meningiomas. Right?
Yes, sir.
Same way for craniopharyngiomas, which are in the supracellular. Clean the scope. Craniopharyngiomas, which are in the supracellular region, we do this transplanar approach. I'll show you where the infundibular stalk is and I'll tell you how the craniopharyngiomas are classified. Okay?
Yes, sir.
Yes, sir.
By and large, you would do a transplanar approach for craniopharyngiomas or tuberculum cellae. Now, what has happened is the world over, there used to be a concept. See, tuberculum cellae meningiomas also involve the optic nerves, right? So here,
Yes, sir.
in this approach, you can identify optic canals on both sides. So partly what they used to do is drill out the optic canals and take out tumor which goes within the optic canals in tuberculum cellae meningiomas. Correct?
Yes, sir.
If your tumor goes lateral to these optic nerves, okay, intracranially lateral to the optic nerves, then you don't have too much of control. Those are the tumors you would go more from the transcranial point of view.
Yes, sir.
Right? So you gain good access to everything. The flip side is on the transcranial side, you cannot drill this wall of the optic nerve. You are going to the superior wall of the optic nerve. Right? Here you get almost a 270 degrees exposure of the optic nerve. So the advantages and disadvantages of everything. But by and large, now most of the people in the world select their approach. When this transtubercular started off, everyone wanted to remove all the tumors by this transtubercular approach. Craniopharyngiomas, still one of the best approaches is this. Unless the craniopharyngioma are too extensive, they would be able to remove it by this approach. Okay. Now I'm taking an incision on the dura and I'm showing you all the structures that are seen so that I'm not talking out of thin air. Okay. So this is your superior, go closer. This is your superior intercavernous sinus over here. This is your sella, tuberculum and planum, right? So I'm
Yes,
taking
Yes, sir.
over here. Do we इसे फटेगा scissor दे दे हाँ मेरे को scissor दे दे because इससे कटेगा जीत ऐसा रख steady give me a scissor so here you see what I'm doing. I'm taking an incision on this dura here. I'm cutting this dura up to your superior intercavernous sinus, which is over here. Can you see that superior intercavernous sinus here?
Yes,
Yes,
sir.
sir.
Yes, sir.
I've taken an incision here. Now, for demonstration's sake, I'm going to take another incision going laterally like this, parallel to your superior intercavernous sinus. Okay. What this does is, this we don't have a tumor, but here you have the whole sella which is exposed, or the pituitary gland, I would say. Okay. Same way here, laterally, I would go cut like this, right up to your sinus.
So generally in tumor, what sort of dural opening you prefer, sir?
Yeah, so I leave that to my neurosurgeon. He prefers the cruciate cut. Okay.
Yeah, that is the standard thing what we follow. Yeah.
So Dr. Devpujari prefers an inverted U shape. My neurosurgeon prefers a cruciate cut, and like these dural edges here, he bipolarize it so it actually shrinks away from the tumor here. So
Yes,
we
sir.
like this sort of dural opening. Now you see the advantage of this dural opening. Okay,
Yes, sir.
struggling, I can look straight inside, do whatever surgery I want within the cella without wondering about how to get about my exposure. Clear about this?
Yes, sir.
Come on, give me another sickle knife again. Sickle knife. So, chalega, sickle bhi chalega. So second thing is transplanar. So in transcellular we do this. In transplanar we would cut above the superior intercavernous sinus over here. Okay, go superiorly over here. Give me that same scissor again. And cut this dura. Lift the dura up with the scissor here. Lift the dura, lest you cut anything else, and cut. Lift the dura and cut.
Sir, how to deal with the bleeding from intercavernous sinus?
Yeah, so bleeding from intercavernous sinus. Again, I say neurosurgeons are the king. We can bipolarize this. You see, I've left the superior intercavernous sinus in my way. So
Yes, yes.
surgery, I will take a bipolarize on both sides, and then
Yes, sir. Then cut.
Yes, sir. Prior to taking incisions, we do bipolarization
Yes.
of the
bipolarize
intercavernous
both
sinus.
sides over here, and then
Yes.
cut in the center over here, right?
Yes,
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 sir.
true, sir.
Identifies the cellar and the supracellular area. Is that clear to everyone?
Yes, sir.
Okay, so this is your supracellular area. Now,
Even sir, sometimes temporary clips are also used to separate the intercavernous sinus.
by and large, we use bipolars, but clips
Yes.
are also another thing. And suppose you still have some bleeding from laterally, you can even use Surgisil for small oozers and wait till everything is down. Okay, I'm just going
Yes,
to
sir.
a little bit more laterally. You see more. I'm going to make this cut a little bit more laterally. Sure, are you happy?
Yes, sir.
I'm asking my fellows whether they're happy. I have this habit of fooling around.
Yes, yes, yes.
I keep fooling with them all the time. Okay. I don't move forward till they are happy. If they say they are not happy, I have to do something more.
Yes, sir.
So very nice dissection, sir.
Thank you very much. Thank you. So here you see, now I'll tell you what lesions come where. Give me a sickle knife. So here now you're looking into the cella. Usually
Yes, sir.
do intracapsular dissection of the tumors. Incise the periosteal and the meningeal layer, go intracapsular and remove the tumor. The gland itself is usually in the posterior part, either posterior superior, laterally. The gland can be flattened up on any side. Move the tumor. And again, the best thing is to identify, like already our neurosurgical colleagues have told us, go first here, then push the tumor here, remove laterally from one cavernous sinus side, go to the other cavernous side and remove the tumor completely, and then go to the diaphragm. Diaphragm prolapses down. Even
Yes, sir. Actually, this technique also helps in preventing the arachnoid fall and CSF leak. When you go through the excision of the tumor first, the arachnoids can be preserved so that CSF leak is prevented.
Yes, absolutely. Okay. So that is one. Now go closer. Jeet, you have to show me the supracellular area. So what you can see in the supracellular area, the most prominent thing is your optic nerves. Can you see those optic nerves? So this was the advantage of doing the tuberculum cellae meningiomas from below. You could go and drill out even the optic canals over here. Can you see this here? Optic canals, tumors that go towards the optic canals, right?
Yes.
So we leave it.
Pictures can be clearly seen and can be preserved. Yes, sir.
So we leave it to the neurosurgeons to decide the approaches. That's why it is not easy to be judgmental. They do everything endoscopic or do everything transcranial. It all depends upon our neurosurgical colleagues what they think is a better approach. Okay, as ENT guys, we have to give them the approach that they desire. If they feel, unless you as an ENT guy knows whether this approach is better or that approach is better, then you can be of use. Now, what can you see over here? It's a beautiful. What you can see is your optic nerves, and here you can see vessel. Can you see this here?
Yes, sir.
But your go closer, go closer, go closer. This is nothing but your superior hypophyseal vessels. Can you see this here?
Yes, sir.
This is superior hypophyseal vessels. Here you can see the arachnoid. Can you see this?
Yes, sir.
ठीक से बता. Here you can see arachnoid. I'm opening up this arachnoid. These blood vessels are supplying the pituitary stalk as well as the optic chiasm. They form an arcade around the optic chiasm, correct?
Yes,
So what
sir.
I'm doing is I'm just opening up the arachnoid without trying to disturb of the vessels, but that's a superior, superb view of your vessels.
And what you can see there is also your hypophyseal stalk, I mean pituitary stalk. Okay. Shada, can you see the superior hypophyseal vessels on both sides? Yeah.
Yes, sir. Sir, sorry to interrupt. We warmly welcome our Medical Superintendent, PDUMC Civil Hospital, Rajkot, Dr. R.S. Trivedi, sir, in the audience with a round of applause.
Thank you very much, sir, for gracing the occasion. And we thank you again for giving us the opportunity to teach. It is because of all these teaching activities that the level of ENT in our country is going higher and higher. Okay. So thank you very much, sir.
Thank you so much, sir.
Okay. So now you can see everything. Is it focused for you all? Can you focus on the stock, Jeet? Go closer. Okay. Focus on the stock. Focused है. Blood vessel दिखना चाहिए. Focus करना.
Sir, before that, we want to see the all carotid exposed.
I'll show everything.
Yes, sir.
I'll show everything today if you want. Okay.
It is very necessary to preserve these hypophyseal vessels for permanent damage to the pituitary stalk
Yes.
and permanent hormonal replacement therapy to prevent it.
So here you can see I'm pulling this superficial, superior hypophyseal on one side. Can you see this?
Yes,
Can you
sir.
see here? This is superior hypophyseal on this side. See this? It's getting pulled now. Can you see this?
Yes, sir.
Superior hypophyseal on the other side. Similarly, inferior hypophyseal, go down. You can see it here. Go down. Can you see it here? Inferior hypophyseals. Yeah. So
Yes, sir.
all this vasculature needs to be preserved. You need to be very gentle. So although you see this is a cadaver, we are going very gently preserving everything, like we would do in a normal individual, right?
Yes, sir.
Yes, sir.
Here you see now a pituitary stalk is preserved, and you all know craniopharyngiomas, how they are classified, right? You have pre-infundibular, you have trans-infundibular, you have retro-infundibular, and stalks, I mean tumors going up to the third ventricle, correct?
Yes, sir.
Pre-infundibular come out thoda. You can easily remove by this approach. Can you now see why? Because you have the sella exposed, you have this exposed. Pre-infundibular endoscopy is the preferred approach, right? Same with trans-infundibular. So even trans-infundibular, go closer. The endoscopy is the preferred approach for trans-infundibular craniopharyngiomas. Retro-infundibular craniopharyngiomas will come into this region over here, right? Difficult to access with these superior hypophyseals, pituitary stalk, all in the way. So one procedure which has been described is pituitary transposition. So what do they do? Pituitary transposition is they take this, you identify your gland, go to the periphery of the gland over here, correct? And
yes, sir.
Here I
One-
don't have the correct instrument. Yeah.
The one thing I would like to tell over here to the beginners that in craniopharyngioma basically is a benign tumor, but it is the only benign tumor which is invasive in nature. So craniopharyngioma always presents with invasiveness of the local structure. So we should be very careful while removing the craniopharyngioma. We should not go in a phase that I will remove the entire tumor.
Near total removal.
We
Always.
should always go for near total removal and preserving the vital structures,
Yes, true.
particularly for craniopharyngioma.
Yes. So here you see what we are doing. We are trying to go behind the pituitary. So correct way to do it is now, they even take this part of the, the dura and lift up the whole pituitary. Okay. I'm not lifting up with the dura. I'm going here. The pituitary here is attached to the side with ligaments. Can you see this?
Yes, sir.
Yes, sir.
So here you'll have multiple dentate ligaments, and then you have to sort of separate all these ligaments here and sort of move this pituitary much more laterally. I mean medially, sorry. Can you see this? Go into this area.
Yes, sir.
Go into this area. Yeah. So like this, you're going here, and when you go here, you're getting bone. This is nothing but bone of the posterior clinoids. Okay. When you drill this, you get the basilar on this side. But here you see, I've gone retro or behind the pituitary gland. If I lift it up with the dura, can you see this dura over here? If I lift it up with the dura over here, that is hemi-transposition. So earlier they used total transposition, then they realized it's giving too much of hormonal disturbances and vascularity of the pituitary stalk, everything is lost. So they started doing hemi-transposition. So this is nothing but hemi-transposition, where now your dorsum is exposed. Okay.
If you
Yes,
do
sir.
both sides, it becomes total transposition. And what does it give exposure to? Show them here. Let me cut this 1 minute. So this is how you go dorsum. Okay. Go to the dorsal end, making sure that you're taking all this dura and the pituitary. Can you see that now? So if
Yes, yes, sir.
transposing this here, you be careful not to take the vasculature. Now, this area contains, as you already told you, lot of perforators supplying the hypothalamus. So you have to be very careful of all the vascularity. Come, hold out the jeep, hold out. But can you now see what I've done? I've taken the pituitary out of my way over here. Can you see that?
Is it a meningo-hypophyseal branch?
Yes, that is the meningo and hypophyseal branch. Okay. So you get bleeding because you get the inferior, this thing.
Directly come from carotid.
Correct. You get the trunks coming from the carotid directly. The meningoencephalus, missing the word.
Meningo-hypophyseal.
Meningohypophyseal trunk also, and even sometimes the inferior hypophyseal. Okay.
Yes.
This is all hemi-transposition. Can you see that now? And what that gives you access to? That gives you access to the dorsum pituitary over here. Give me a second.
Not only the vessels, but even the oozers would be there while doing dissection in this surgery. So we should be very careful about it.
Yeah.
And mechanical pressure using F-gels, and that should be very much required. The patients would be the most thing that would be maintained throughout the surgery for blood control.
Yes. So this is what we are talking of hemi-transposition to look back. If I remove all this, you can approach tumors over there. Okay, I mean, I would have to remove a little bit more of this dura over here, and you'll be able to do. But suppose you have to deal with tumors going from there downwards, you could drill out this dorsum sellae. Okay, you could drill out this bone and remove this bone completely, and that gives you exposure to the basilar top to bottom. Okay, not top to bottom, but really the upper end, I would say. Now look in and see what else can you see. Okay. Let us see if we can see any other structures of importance. Here you have the optic chiasm. Hello.
Sir, how to differentiate between normal pituitary and tumor tissue?
Okay. Tumor tissue is exactly like fat, almost like soft and fat. Pituitary gland is normally very pinkish. Okay, vascular, so and fleshy. All right. So now you have a.
You in craniopharyngioma, you may have mixed structure. You may have some hard tissue.
Yes, hard hard tissue. You could have calcium. You could have soft tissue. You could have cysts. You could have everything. So that's where we require you neurosurgical guys. Okay.
Generally, craniopharyngioma would present with different kind of tumor consistency. It can be a solid tumor, it can be solid cystic or a cystic tumor. So generally, the difference between craniopharyngioma and pituitary, generally the pituitary tumors are rubbery kind of thing and the soft suckable tumors generally. In craniopharyngioma is generally hard in consistency and invasive in nature. So if you are removing a pituitary tumor, if it's soft suckable, it will start falling on its own, and the pituitary gland would be little bit firm as compared to the tumor. So technically, what we are telling is red color and everything, but with experience only, it would be confirmed that this now you have entered into a pituitary gland or thing. So basically, it's the consistency which will help you in differentiating the tumors from the original pituitary glands.
Yeah. Thanks. I'll just have a sip of water. 1 second.
Craniopharyngioma basically is a bimodal tumor. So generally it would be seen in either first 2 decades or it would be seen after 4th decade of life. So craniopharyngioma generally it's not seen only in cellular region. It will always, according to my experience, cellular supracellular extension is always there for craniopharyngiomas. And craniopharyngiomas generally have not only solid but solid cystic component is more common because there is a degenerative changes that is seen through the progression of the tumor. So the appearance of craniopharyngioma is mostly solid cystic in consistency. Pure solid or pure cystic is rarely seen. And when it is pure cystic, the best treatment is just to put a shunt over there and Omaya on. You just aspirate it each time and you provide the chemotherapy in such tumors. So it becomes very easy for, instead of going for excision, just to aspirate through by putting stereotactic shunt and then giving the chemotherapy in those cavities that resolves over a period of time. And even it prevents the deficiency of hormones throughout the treatment.
Okay, good. 1 minute. Jeet, can you put it in? I'll show a few structures now. That's a beautiful summary of craniopharyngiomas. And
Sorry to interrupt, sir. We heartily welcome FM Department HOD Dr. Kyada, sir, with round of applause, who help us for arranging cadaver. Thank you so much, sir.
thank you very much. Thank you very much. You can see this excellent cadaver. And thank you very much to the forensic department for this. Okay. Without this fresh cadaver, our dissection would not really look as good. Okay. So thank you very much, sir.
Thank you. Thank you.
It looks like a live body only, what we are seeing over here. Very nice dissection, sir.
Thank you. Can I go on with my dissection?
Yes, sir.
Okay. So as I look inside here, you can see the optic. You can see here, this is the carotid. Can you see that? This is the carotid. And what is the first branch that comes out intracranial from your
Ophthalmic artery.
ophthalmic artery? You can see just coming as a small outpouching and goes back towards the orbit. So the first branch intracranial or intradural is your ophthalmic branch here. Can you see that? Just over the carotid, this is carotid and this is the ophthalmic branch coming out over here. Can you see that?
Sir, can you dissect more this ophthalmic branch so we can see the relationship with optic nerve?
It is just here. It's
No,
just
but for the optic nerve decompression, we have to take care of this. So if you dissect it more, so we can see how it's lying in relation to optic nerve.
we'll show that later. Right now, I want to show something else more important. You can just believe me that there is an ophthalmic artery over there. Okay. Okay. Let's just go in here. There's some fluid. Give me a smaller suction, otherwise the blood vessels will get pulled out. I'm just going to show you what lies in the dorsum celling. Okay. And what areas is through that area. Give me a smaller section. You can see CSF coming out. And that's why before you do these transcubicular transplanar approaches, you need to understand that you need to plan your reconstruction, right? Like I told you, most of the time we would think of doing Haddad flap, various ways to do it. Just a Haddad will not suffice. The first layer has to be fat. Then over that fat, we then tend to put other layers. Okay, we can do gasket seal technique and various other techniques. Come out thoda. Okay. Let me see if I can show you any other structures on the inside, right? So this is nothing but a part of your Lilliquist membrane, correct?
Yes, sir.
So I'm taking this Lilliquist membrane, go inside for a deep. Okay, and what you can see over here is multiple blood vessels, correct? I'm opening up the arachnoid over here. What you can see here is the mammillary bodies. Can you see that?
Yes, sir.
Yes, sir. Yes, sir.
Bodies. And here what you can see is branches from the basilar here. Jeet, bata na. Yeah. Come out thoda so I can suck. I'll suck out a little bit. Go in. Can you all appreciate the from the basilar? This one? Okay, they look like a coconut tree. Can you see this?
Yes, yes, sir.
So these are
Very nice.
from the, this thing. The first branch up here would be the posterior cerebral, little bit the superior cerebral. Okay, superior cerebellar, sorry. And between the two here, give me a minute. Hey, let me go in.
Can you show us the abducent there, sir?
Third nerve will come here. Abducent will come much down. The third nerve, this is third nerve here. Okay, Jeet has to show you. I can
Yes,
see.
yes.
Can you see that this thing third nerve there?
Yes, sir.
Third nerve you can see beautifully. The superior upper one here is nothing but the SCA, and down here would be the PCA. Go show down. Niche dekha na thoda. Okay. Anyway, the bone is coming in the way. Let me show. 1 minute. Okay. Let me show you this part. Sorry. Yeah. Posterior cerebellar and superior cerebellar. I'm sorry. Webb have corrected me. The superior one is SCA and the PCA. Sorry. PCA and the lower one is SCA. And between the PCA and SCA here, you can see the third nerve. Can you see that?
Yes, sir. Yes, sir.
PCA superiorly, that's the posterior cerebral.
and SCA is nothing but the superior cerebellar. Okay,
Yes, sir.
this is between the two. You can see this nicely. There's a third nerve over there, right?
Yes, sir.
All there. Here you can see the mammillary bodies. And if you want to go into the third ventricle, if I open this thing up here, you go into the third ventricle. Okay, I have to go interthalamic between the mammillary bodies and look into that space for your third ventricle. Do you want me to go there?
Yes, yes. You can show the foramen Monroe, sir.
Okay. So neurosurgeons are not going to kill me now. I want to go back to Bombay.
No, sir.
Okay.
So this PC and SCA would be the culprit for trigeminal neuralgia if you still go further.
Yes.
This would be causing trigeminal neuralgia.
Yes. So trigeminal neuralgia, we usually do go by the retrosigmoid route.
Yeah,
Yes,
no,
sir.
no, I agree, but this would be the vessels would be the culprit for that pathology.
Yes, true, sir.
So here you can start seeing the mammillary bodies, interthalamic striae, and there if I go into the region of the third ventricle. Can you start seeing this now?
Yes, yes. Sir.
I'm going.
Very nice, sir.
Give me a suction. I'll have to use a suction here. Sorry. Just come back out.
Very thin suction required, sir.
Yeah, I know. Let me see if I have. I don't think I have such a thin suction.
It is thick, sir, I think.
Yeah, I know it is thick. So
It
I
will not work.
have to go only with my scope and hope it goes. Okay, so that's going inside. And if I go inside this, you're getting your choroid plexus. You should get. Okay, let me go inside. There.
Oh, great, sir.
Yes,
Excellent.
Now you can see your choroid plexus.
Yes, sir.
I'm sucking out all the fluid there. Lot of fluid. And there you can see. Can you see that?
Yes, yes, sir.
Okay, it's wonderful to look into this part.
Yes, very
Yes,
nice,
sir.
sir. Very nice, sir.
So that's how you go into various aspects. And that's how your craniopharyngioma goes superiorly towards the third ventricle.
A huge round of applause here. sir.
Very good dissection, sir. Very good dissection.
So that's how your this thing craniopharyngiomas go towards the third ventricle. So when they go towards the third ventricle, they block. Give me a sickle knife. Sickle knife, did it. When they go towards the third ventricle, any tumors that pushes against this area will cause you some amount of hydrocephalus. Correct?
Yes,
So
sir.
then you need to take it out quickly. They'll end up with headaches and they get hydrocephalus. Okay, so this is your all the structures that are visualized through this approach. Now here again, one thing which I forgot to show you is give me a Freer's elevator. Superior, you have seen everything inferior to the optic chiasm, pituitary stalk, pituitary gland. You have seen the PCA, SCA, third nerve, dorsum sellae. You have seen the liliquous membrane. You have seen the mammillary bodies, interthalamic striae. You have seen the carotids, ophthalmic branches. Now here in this area, what is prolapsing here is nothing but a part of your frontal lobe, right?
Yes, yes, sir.
Give me a Freer's elevator. So minute I lift it up, you should be able to see something. The neurosurgeons know what is coming up. For the ENT people who don't know what's coming up, I'll just show you in a second. There. What can you see there? Okay. You can see two blood vessels there. Hitesh bhai,
Yes,
maybe
sir.
this is A1, ACOM, and ahead of that is A2. It's like an H.
Okay, sir.
Okay. So give me a sickle knife here. So this is A1 on this side. This is A1 on the opposite side. They join together like an H and they form a bridge. Can you see that bridge? That is called the ACOM.
ACOM.
Yes, sir.
Beyond that, it goes as A2s. Okay, so this is all a part of your anterior circulation. So this is anterior circulation. That basilar there is a part of your posterior circulation. And all of them combine in this region and give rise to the circle of Willis.
Willis.
Correct?
Yes, sir.
Yes, sir.
This is all you can access from here. Now, I'll show you what lies below this over here, and you wanted to see the abducent. Give me a drill. Good. Clivus. Okay. Give me a suction, man.
Sir, last time you had shown the Dorellos canal.
Okay. So we had this debate and fun at Vashi. So Satish was showing clivus and abducens and all from the endoscopic view, and
Yes.
I showed him from the lateral view. Okay.
It's like, sir, ye dil mange more.
Yeah. So I don't mind showing dissection all day long. Flight cancel karo. I'll show it tomorrow also.
Thank you so much, sir.
Thank you. Okay, now what we are doing is transclival. You can see this.
Yes, sir.
Now I want to quickly show you carotid, transclival, what are the structures which come here. So at
Yes,
least
sir. Please expose the one side, whole carotid, sir.
I'll expose on one side.
Yes, sir.
Ritesh bhai, this drill is thoda slow. Okay, so you just have
Okay, sir.
to- maybe it takes 15 minutes now. But
Okay, sir.
okay.
But sir, all wants to know, show the carotids. Sir.
Yeah, I'll show you everything.
Yes, sir.
I'll show the entire course of carotid if this drill works well, fast. Go closer. Go closer. एक minute, this thing I don't want it to come. The burr point loose? No, no. जीत ठीक से पकड़, straight पकड़. हाँ, straight orientation रख. burr has come out. मैं बोला तेरे को burr loose हो रहा है. Burr has come out. मेरे को कटिंग भी चलेगा. अच्छा चलो कोई भी है जो तो because this is taking time. The reason I don't use these नहीं कोई बात है नहीं ठीक है चलो ये लगा दिया तो दिखा दो चल तब तक देख लो कटिंग. The reason I don't use like too much of this is because of it's slow compared to the other ones. Yeah, this is doing a good better job. Previous one was not doing anything. ये ठीक है. वैभव कितना बजा? Go closer. So here, when you're drilling the area of the clivus over here, you generally have a lot of oozing from the basilar plexus. Okay, between the bone, you have a venous system. Go closer. Between the bone, you have a venous system, and that
Yes, sir.
that should not really deter you from going about and doing your drilling. Okay,
Yes, sir.
a lot of oozing before you reach bone.
Yes, sir.
Rich vascular supply.
Yes, sir.
So the limits is on both sides. You have to identify your carotids and drill all the bone. क्या हो गया?
What is the average distance between two carotid at clivus, sir?
I wouldn't know that, but it varies from individual to individual.
15 to 18 millimeters, sir, I think.
I don't know the exact. But
18, average 18, sir, I think.
So now you see I've removed most of the bone and now I'm getting all this. Can you see this area here? There's like a rough area. Can you see like a spongy area?
Yes, yes, sir.
Nothing but the
Plexus. Basilar plexus.
Yeah, basilar venous plexus. So that causes a lot of oozing as you drill. I'm just going to expose everything very fast now because I want to show you more and more. Scope थोड़ा clean नहीं है. Okay, that's better. ठीक है. So we do this approach of transclival basically for all your clival tumors, okay? Clival chordomas, chondrosarcomas, or even clival meningiomas. They're very approachable by this removal. Is that clear to everyone?
Yes, sir.
So we welcome President IMA Gujarat State Branch, Dr. Bharat Kakadia sir, with us in the audience with a round of applause. And we also welcome our GMC observer, Dr. Ashok Mehta sir. Thank you, sir, for joining.
Welcome Dr. Kakadia and Dr. Mehta. Good always to see you again and again. I miss seeing Dr. Mehta at Morbi. So, Dr. Mehta, good afternoon.
Good afternoon, Narayan. Dr. Kakadia here. We are
Clean the scope. Good afternoon, Dr. Kakade.
yeah, it's nice to see the excellent dissection.
Thank you. I'm just trying to get maximum exposure by drilling out all this bone, okay? Nothing else that I'm doing. I'm just exposing dura everywhere. I want to show you all the sixth nerve. I want to show you its relation to the carotid. That's why I'm drilling this nicely. I don't have to go back in. I don't struggle to show you that. जीत ये देखा मेरे को carotid expose होता है ये bug देखो ऊपर let me take a little bit more bone.
Sir, once again, sorry to interrupt. Sir, we are planning for a small inauguration ceremony. So if you permit, we can proceed with that now.
Yes, please go ahead. I'm going to go by dissection.
And sir, we'll need your presence here.
Okay.
So, as you say,
yeah, once
for the inauguration ceremony, sir.
You hold on with that. Because मेरे को उधर आके वापस dissection में आने को मुश्किल हो जाएगा. Is it okay for 10, at least give me 10-15 minutes? Is that okay?
Okay, sir. No issue, sir. Yes, sir.
Because once we break, then if I come there, then we can all go for lunch. Otherwise, it'll be a big break from your dissection.
Yes, sir. We'll proceed with the dissection.
Okay. Good. So let me just show this for the time being. Okay. Chalo. Give me a this thing. Keep this clean. Give me a blade. So I'm going to show you what is approachable by a transclival approach. Okay. So here you see, I have gone in here. 15 number blade you gave me. Okay, ठीक है. ये दिखा, नीचे दिखा. So you see all the bone is out. Okay, maybe a little bone is still over here. I should have removed this as well. Little bit bone is here. तो जो भी है तो little bit bone is still on the inferior edge of the pituitary. Cure it. Oh, this is part of your dorsum. No. No, I wanted to remove a little bit more of this bone. There, bone punch there. So we'll just remove a little bit of this bone.
Okay, sir.
This bone is going to lead to your dorsum sending. Okay. So it may sometimes come out as a big chip. We'll still remove whatever is possible. Clean.
Dr. Narayan.
Yeah.
As you had told last time,
yeah.
ICA is the nearest one is 11 o'clock, 1 o'clock, 5 o'clock, and 7 o'clock.
Yeah.
So in live surgery, if we are doing this type of punching, is there any chances of injury to the ICA?
Yes. So this is removal of dorsum sellae. Okay. Now this is a technique I don't want anyone to follow right now. This is done for pituitary transposition. I told you we are removing this whole dorsal bone, correct? I'm doing exposure. But when you do this, this dorsum sellae bone can wind around the carotids. Okay. And then you will pull out the carotids in retrospect. So don't do this. What you have to do is dissect this bone off completely. Can you see me dissecting it off? I told you I was just trying to get exposure, but this is the same dorsum sellae bone, which I told you will give exposure to your whole basilar plexus up there. Okay. For me, I didn't have the notches going around the carotid. So it's coming out. But this will give you a superb exposure of the basilar from down to up. Okay.
Right.
Hence your middle clinoids wind around the whole this thing. What do you say? Carotids. So you have to be very careful. Forceps. So many a time what we do is if there is a sort of a process going behind the carotids. We take sort of shoulder osteotomies and then remove only the central part. Okay.
Okay.
Sickle. So this is all dorsum sellae.
Hmm.
You need to remove all of it. But just for exposure, I'll show you. Give me your forceps again. निकल इधर गिर गया. इधर ही किधर रह गया. कोई बात नहीं. चल अंदर ही गिरा.
So exactly you define dorsum sella as a posterior part of sella turcica?
Yes, absolutely. This is where exactly the bone is coming out from.
Right. And then it goes to the clivus.
And this is most inferior wall and the posterior wall both coming out together. Okay, we'll leave it there for the time being. I just wanted to show you in continuation from down top. If it bothers, I'll remove it. Give me a sickle. The idea of removing this is I wanted to show you the basilar from bottom to top. Not a very difficult thing. We can still remove it. It's just a very small thing.
Yes, sir.
There it's come off. Give me a
Slight periosteum.
yeah. So bleeding is always from the venous plexuses. It should not bother. Usually some amount of liberal irrigation, a little bit of surgicel and all, but clival tumors will ooze. You should expect them to ooze. But this area is richly supplied with a venous plexus.
Yes.
Okay, that's bone is out completely. Okay, take this. Now give me a sickle. Now I'm just going to open up this clival dura. This clival dura, again, you see, it has two layers, one periosteal layer and meningeal layer, right? So I'm opening up this dura. Can you see CSF immediately?
Yes.
Okay, so I'm opening this up. I'm going to give it a cut. Let me open it from down. Give me the scissors. Now here you must understand what I'm expecting to find there. Okay, I'm expecting to find the basilar. Basilar can be in the center. Basilar can be ectatic. So idea is your scissors must not take the basilar, right? That's the whole idea.
Yes. Yes.
So give me that sickle once again.
So ideally, we can use a blunt hook over here to elevate the arachnoid and dura.
Yes. So I'm just making a small incision here with the help of the sickle, and then I'll extend it through the sickle itself. See, I'm lifting the dura up, making a small nick there. Can you see that?
Yes, sir.
PSF. So with this, I'm unlikely, if I lift only the dura, I'm unlikely to hurt the
artery.
Go in. I think it's my instrument. Okay.
So you require such kind of exposure in craniopharyngioma?
Yeah, not craniopharyngioma. This is all for clival tumors.
Clival.
Yeah. So all these are clival tumors. Yeah.
We can see the brain.
Even sir, nowadays few advanced centers are using this approach for basilar top aneurysms also.
Yes, basilar top aneurysms can be done by this. That is called level 6 according to Amin Kasam. Level 6 of endoscopic. Okay.
Yes, sir. Yes, sir.
I think, but still, many people would prefer to do it by the natural, retrosigmoid approaches.
Yes, sir.
Because this is all posterior fossa now coming up. Okay.
Yes.
Let me just open this up a little bit more if I can. So I have to watch my basilar at all times and then open it up. You see, I could have exposed my bone a little bit below. You would have seen the vertebro-basilar junction soon. Okay.
Yes, sir.
Centimeter down, you would have seen the vertebro-basilar junction. Okay.
Okay.
Okay. So give me the sickle knife now. So here is the basilar. Now what I want to show you is this area here. Can you see this? I'm opening up this dura more. Give me the scissor. Let me open it up properly. Bata mere ko scissor de. Jeet, go closer. Go up. Go up.
So presently you are going forehand technique?
Yeah, forehand technique. So Jeet is showing me.
Beautiful.
Endoscope. He is holding the endoscope.
Yeah, they've all been trained. This is why Jeet and Weba were doing a fantastic job over here. Okay. I think it's not always us, it is about how they pick up. Chalo. Textbook picture. Good, na? Yes. Yeah, take a picture. Akshada, you won't get to see this every time. So here you see, I've opened up the dura. Okay. And here I'm exposing you the whole basilar from the clivus. Okay, just a little bit down would be the vertebra basilar junction. This would be the basilar.
And vessels.
Yeah. Akshada, take one more picture, please. This is the pituitary stalk which I've taken away. Otherwise, this pituitary was right in the way. I've pushed this pituitary over here. Can you see?
Yes.
1 minute. Again, Jeet, इधर से आजा. जीत 1 minute. इधर से आजा. इधर से. हाँ. Can you see everything now?
Yes, sir.
So you have almost a panoramic view of everything that's possible. Take multiple pictures, huh?
Can you just illustrate everything?
Yes.
Branches and everything.
I'll illustrate everything.
Yeah.
Okay. So here you see this is the basilar.
Yes.
That is nothing but the SCA. This is the PCA. Okay. You can see beautifully the third nerve running between the PCA and the SCA. Correct? Third nerve. Third nerve going like this towards the cavernous sinus.
Yes.
Right? I already showed you the structures that are superior to this. Now here, this is all down going towards the midbrain or the vertebrobasilar area, right?
Okay.
Now, if I go laterally, I'll show them the abducens. So the sixth nerve should come here. So like Amin says, third nerve, this is all a part of upper clivus. Okay, so third nerve is a part of upper clivus, right? Middle plus sixth nerve is the main nerve, right?
Yes.
Akshata got a nice picture.
And it is most medial one?
Yeah. Akshata, you're blocking my view thoda. Okay, thank you. Okay, thoda idhar bata. So give me another ballpoint probe or something. Thoda aisa. Okay. So the sixth nerve starts bottom at the level of the vertebro-basilar junction, comes like this and goes behind the carotid. Okay. I'll show you how it goes behind the carotid and goes past the Dorellos canal and goes into the lateral cavernous sinus. So here, my idea is to try and show you the sixth nerve. So I'll tease out this arachnoid a little bit. So you have to tease out the arachnoid. You have to drain out a little bit of CSF. And then if you're good enough, if you're lucky, we'll show you the sixth nerve all the way from down going up. Okay. The arachnoid is blocking the way. Niche bata thoda. That's the correct. Oh. I have to tease out this arachnoid because this arachnoid is blocking your view. I'm opening up this arachnoid here. If I push this midbrain here, go in. That's 7th, 8th nerve. No, this is, yeah, lower cranial nerves. Kya? Bata, 1 minute, give it to me. I think I'll take up the scope for a minute. Give me your fears. Agya? Okay, no, my orientation had changed. Thoda angle tha na?
Yes.
Come down. So this is third nerve. Now if I move this over here, okay. That's fourth nerve. Can you see that?
Fourth. Yes.
Fourth there. Just there. Thin nerve there. Can you see that?
Yeah, yeah. Quite thin. Then the third nerve.
Thin nerve over here. The fourth nerve, correct? Now, as you go down here, let us see if we can see. I need a suction over there. नहीं. देखो suction देते, वो round suction देते, so it doesn't hurt any nerve. So the sixth nerve is generally stuck to this thing, prepontine area. It's all the pons, prepontine area. It will be stuck over there and it's very thin, fragile nerve. I'll just hopefully show it to you in a second. ऐसा करते तो suck करेगा? I'll move it, just suck gently. इधर से डाल, इधर. एक minute. It will come out. Cut tips निकाल. जी take minute. I don't think the suction is going there. It's little big. ठीक है. This is sixth nerve. Can you see this here? Can you see the sixth nerve here? Ahead, front. Not right at the back. Here, just here. Unless there's an arachnoid band. Wait. Sorry. It'll just come right over here. This is not the sixth. There's an arachnoid band. अभी sixth आ जाएगा. Just there. I need some suction over there. एक काम कर, suction को बाहर ही रख. दिख रहा है मेरे को six. Suction को बाहर ही रख. It'll anyway suck. All the fluid will come out. It's all CSF. इधर ही रख. पकड़. So seventh, eighth nerve complex is a little superior to your sixth nerve. Okay, I can just see the seventh, eighth nerve complex over there. Can you see that? It's lower cranial nerve. उसके पीछे जा.
No, sir, it's not clear from here.
Yeah, there is all CSF over there. We are not able to get a suction in there at the same time. Go in. Okay, done. Suction done. Done. Now you'll see the sixth nerve. Suction drug udhar. There. Can you see now? Okay, hold on. Can you see the sixth nerve over here? Here. Here. Not make it out?
No, it's not clear from here, sir.
ये देखो, I'm opening this. छोड़ दे.
So you can point out with the ball point.
Can you see this here?
Yes, sir.
Yes,
Yes, sir. It's in now.
It's going quite
Above.
laterally.
Yes, sir.
Now it will go into the Dorellos canal,
Very good, sir. Dissection.
and you'll be able to see it going from Dorellos canal back under the carotid. Got it?
Yes, sir.
Sixth nerve is much more deeper than the seventh, eighth nerve. छोड़ दे. निकाल. Sixth nerve is more towards the center. Seventh, eighth nerve will come more towards the outside. Okay, let me open this. Can you see this?
Yes, sir.
Can you see the sixth nerve going in here?
Yes, sir.
Yeah. This one here.
Yes.
That is fourth, sixth. Okay. And just below that here will be your seventh, eighth nerve complex. Little difficult to show with the arachnoid there and the CSF coming.
Too much angle.
You're not supposed to go there, okay? In short, दिखा तो सकते हैं, लेकिन you're not supposed to do the surgeries of seventh, eighth nerve from there.
This route, yes, sir. 7th, 8th, and 5th seen through retrosigmoid route easily.
So more times you get clival chordomas, etc. And the first nerve to get involved is the sixth nerve, because sixth nerve is the nerve related to the mid clivus. Okay. The third nerve is the first nerve to get involved in these lesions here, which is related to the upper clivus. And lower clivus is again the 12th nerve, lower cranial nerves. Okay.
Yes, sir.
This is the mid clivus. If I drill down, I can go to lower clivus. For lower clivus, I have to remove this entire bone and go up to dura. All this. And we can go from here right up to your the atlanto-occipital joint. Right? If I go straight down on this. But I think for now, this anatomy should be enough. Right?
Right.
As far as carotid is concerned, here I just take out this and show them how to go to carotid. Give me a punch, bone punch.
Sir, can you show us the lateral wall of cavernous sinus and all related nerves?
Yeah. So I'll try to take out this bone and show you the lateral caverns.
So Hitesh is worrying about day-to-day problem.
Pardon?
Hitesh
Sir,
is
it's
worrying about day-to-day
Sir,
problem.
it's really important, sir.
Okay. So by and large, let me show you. This is little dura. There's still some bone I need to remove, but I'll show you in shortcut. Bone punch दे, नहीं तो मेरे को बाद में bone निकालना पड़ेगा. I'm just removing out some more bone. Okay, okay. Give me a sickle knife. So by and large, when you see, you know that this is the carotid, correct?
Yes, sir.
You'll know that this is the carotid. This is the paraclavial carotid over here. Okay, this is the vertical limb of carotid. There's some bone over here. Let me remove this bone chip. Dave, straight for some. Give me a, okay, give me a second, no problem. So here you see, this is the paraclival ports of the carotid. Carotid
Yes, sir.
turning like this and going here. And when it goes intracranial, can you see that going intracranial?
Yes, yes, sir.
And intracranial part, you can see the first.
Ophthalmic. Ophthalmic artery.
Okay. So if I drill more over here and go laterally, this is going to be the region of the foramen
Lacerum.
lacerum. So if I drill out all this bone, I will get the foramen lacerum over
Yes,
here.
sir.
And from there, it will go onto the surface of the temporal bone that's on the greater wing of the sphenoid, and that is a petrous segment of the carotid. Correct?
Yes, sir.
Now,
Yes,
when
sir.
we move pituitary tumors, we go into the medial cavernous sinus here. Okay? And through the medial cavernous sinus, we put in a suction and try to drain, take out all these tumors. The medial cavernous sinus wall breaks, and these tumors go from here into the lateral cavernous. Non-functional tumors, you still go from here. Functional tumors, you may need to expose this area lateral to carotid. Okay.
Okay. Okay, sir.
Size on this sheath lateral to carotid. The region you will, the area you will incise is somewhere between the V1 and V2. Okay. I'm just showing this over here because this bone needs to have gone. But I'll just show you the course of the carotid and where is the lateral cavernous. And we go for this only in lateral cavernous sinus tumors or functional tumors if we require complete remission.
Okay.
So you need a Doppler. If I take a sickle and go into the carotid, there'll be only God to save me. Okay. So
Yes, yes.
I don't know. In this, I'm doing roughly, correct? I may be in the carotid lumen. How do you know? So ideally, you need a Doppler to identify your carotid. Go far lateral and then incise in the dura lateral to carotid. Okay.
Yes.
Okay.
Yes.
If you're doing what I did now, you're taking a chance. It's possible you may also go into the lumen of the carotid. So that's why Doppler is very important. Here we are taking this out, and thankfully I've left the carotid intact. Can you see that?
Yes. Yes, yes, sir.
So I'm lucky. I always told everyone I'm a lucky surgeon.
True.
See this. Now you can see the carotid nice over there.
Yes, sir.
You can see how the dura is covering the carotid. You mean that I told you I may have to remove more bone over here, but I'll still manage to do it. ये देख. No, I'll just remove this dura which is holding it back. Okay. So the segments of the carotid which are, you have the paraclival segment, the paraclival segment over here. Okay. You have the horizontal limb.
Yes, sir.
Okay. We call it the anterior bend over here. Then it curves around and becomes the posterior bend and goes into the cavernous sinus. Okay.
Okay.
So this is posterior bend. This is anterior bend. This is the cavernous segment, and then is the intracranial. So here you have the proximal and the distal dural rings, between which is the clinoidal segment. Can you see this is a part of the clinoid?
Yes, sir.
I'm going to remove this bone because this is part of clinoid. So between this here, proximal dural and distal dural ring is a clinoidal segment, after which it goes immediately and becomes intracranial here.
Yes, sir.
Okay. Are the neurosurgeons okay? Am I okay with the anatomy stuff?
Yes, sir.
So that particular thing
He said
we
yes.
can make out by the OCR.
By the?
Opticocarotid recess is related with that thing.
Yeah. That's right. I need to remove a little bit more bone. Give me a. What will you give me? Take a second. Look. I just hope some more bone has to come out. If I'm going to show you convincingly the third, fourth, sixth, and V1, I have to convincingly remove some more bone. But let me see if I can. I told you I'm a lucky surgeon. If I am lucky, you'll see 3, 4, 6 now also.
Yes, sir.
Let's see.
Yes.
Yeah, I'm a lucky surgeon. Focus.
Yes, yes, sir. We can see.
Give me that scissors. Dural scissors, tha na?
3, 4, and 6 we can see, I think, sir.
Yeah. So 3 is the fattest nerve there. 6, the 4th is a very, very tiny nerve.
Yes, sir.
Okay. Give me a ballpoint probe. Let's see if we can show it convincingly. Chalega. Don't worry about it. Okay. Can you see this?
Yes, yes, sir.
This is nothing but your third nerve. Can you see this?
Yes, sir. Yes, sir.
It's the third nerve.
Fatty nerve.
Third nerve here, just inferiorly and down here. Focus karega, Weber.
Fourth.
Focus कर दे better.
This is fourth, yes.
नहीं, focus कर. We are just trying to focus it better. Okay, yeah, okay. Give me a sickle. Fourth is stuck over here. Okay. So fourth is a very thin, slender nerve. Okay, and it will
Yes, sir.
laterally, and it will run deeper to the third nerve in this inferior quadrant. By doing this, I hope I don't damage it. It's just over here. This one. This one is fourth nerve here. Okay, one which I'm pointing to is fourth nerve. Third nerve, fourth nerve. Same way you'll have sixth nerve coming a little deeper down. Sixth nerve enters the Dorellos canal over here, goes behind the carotid, and comes out into the lateral cavernous over here. Okay, let's see if we can show you that as well. See, your sixth nerve is coming down here. Can you see this here? Yeah, here, just over here. And you can also mistake that for V1. Okay, that could be V1. I do not know. Sixth is also a little small, but you'll probably see V1 also coming there. Can you see this now? Focus karna.
Yes.
So if it is very thin, it is probably 6, otherwise it's V1. It's probably V1 according to me. I don't know. Let's see. Yeah, it's probably 6th. It is 6th. Okay, so we were correct about it. Third nerve, fourth one was just a little bit here as a slender nerve, just over here. This is 6th. And V1, I'll show you just deeper to this. Here. Can you see this? Under this little bit of arachnoid. Here, this is V1. Can you see that?
V1 is the thick one?
This is 6th.
Right.
This is V1. Can you see? Can you see V1? There's a head here. Slender one here, just here, and that's third. All clear? Or not clear? I didn't hear a clear from there. Or
Yes. No, no.
Yes, yes.
if you're not convinced, I'll show you again. See, you can see it so clearly. Can you see?
Yes.
See the nerves. If I tease it more, you'll see it better. But can you make out? This is third. The thickest one is third. Okay. Niche jo thicker one here is 6th. Can you see this? I'm touching on 6th here. This.
Yes, yes.
4 is slender. It runs under this. I have to open up this plane a little bit more. It's a very slender nerve running here. Okay. And here is the V1 here, just here. See this. Can you see?
Most inferiorly.
Can you see?
Yes, yes, yes.
This is V1. And now you see 3, 6 and V1 all in the same frame.
Okay.
Right? 3, 6, V1. Take a picture, Akshara. Won't get this again. You can see all of them, right?
Right.
And that's your carotid. So that's your lateral cavernous sinus. This is your medial cavernous sinus. You can see how your sixth nerve is going behind the carotid and coming out into the lateral cavernous sinus. Okay?
Okay.
So this is all the anatomy that I require to show you. The area anterior to this cavernous sinus is nothing but your superior orbital fissure. Okay, just anterior to your cavernous sinus. So what do we do? Should I come down for inauguration and we break for lunch, or should we go on?
Inauguration.
Dr. Sejal, you want me to
Yes,
come?
sir. Sir, we are proceeding ahead with the formal inauguration function followed by lunch. And sir, if there is you wanted to show more the things on dissection, then post lunch we will continue dissection or either lecture, whatever you prefer, sir.
Everyone wants to see. I'll come down now for lunch, but you all decide what you want me to do. Well, if you want me to show dissection, I can. If you want me to show some lecture, we can. Depends on
Sir,
time.
everybody wants a lecture regarding how to read a CT scan and as well as regarding the prevention of the complication during the phase, sir.
Okay. So,
Post lunch session, sir.
so I hope you'll enjoy the dissection. This is the end of the dissection for the day then. Okay. And I'd like to thank everyone here, the OT staff, all the sisters, all the technical helps. Everyone have been very, very helpful. Stores, Medtronic. Are you listening? Stores, Medtronic. Sab sun rahe kya?
Yes, sir. Okay.
I need to tell them they are our sponsor. They're helping us. So we need to tell them also thank you.
And
Okay, sir.
some of you guys are Dr. Divya, Dr. Raj, Dr. Gaurav. Okay? Thank you.
Okay. Okay, sir. Thank you so much. We are waiting you here as a part of inauguration function, sir. Please come, sir. Yes, sir. हाँ, चालू करो. हाँ, हाँ. बोलो. Hello, everybody.